As I've said, welcome to the third of the showcases for 2024. My name is Professor Dick Sandford, and I'm the Clinical Director of the East Genomics Medicine Service Alliance. So I'm sure some or many of you will be very, very familiar with the NHS Genomic Medicine Service, certainly by name. Some of you may have already used the GMS to order genomic tests, but as I said from our previous surveys, I think there's still gaps in knowledge and experience within the NHS workforce in terms of using genomic testing. So in the East Genomic Medicine Service is comprised of two main elements. One is the East Genomic Medicine Service Alliance, and together with the East Genomic Laboratory Hub forms East Genomics, and we are one of 7 genomic medicine services across NHS England. On this particular diagram you can see us shaded in blue. And what the Genomic Medicine Service is designed to do, it's aimed to ensure that there is equal access for eligible patients to nationally commissioned genomic tests. And these tests are set out in a document called the National Genomics Test Directory. So no matter where people live, which specialty they're being seen in, at which hospital, they have access to appropriate testing. And of course, the Genomic Medicine Service therefore needs to be providing support for the establishment of these testing pathways, and in particular in cancers and rare disease, although newer indications are being developed all the time. And of course, we are there to assist anybody within the NHS to order genomic tests if it's part of an approved care pathway. And clearly, we're also always thinking about next steps. So we're thinking about introducing new models of care that perhaps support early access to genomic testing that result in high quality personalised treatments and potentially screening as well. Next slide, please. And this is the East GMSA GMS geography. So it's a complex geography spanning what we generally call the East of England and East Midlands. It has a substantial population of about 11 million people and covers, I think at the last count, 11 NHS trusts, and those are acute trusts, mental health trusts, community trusts, and services there are also commissioned and delivered by 11 different integrated care boards as well. And within our region, we have 3 laboratories, genomic laboratories, the Genomic Laboratory Hub based in Cambridge, and 2 additional laboratories in Leicester and Nottingham. So it's a large and complex geography to provide genomics to the East population. And just to show you a little bit about what the structure of the GMS in this particular region looks like, and very similar in all other NHS England regions. And this just shows what I've already briefly mentioned, that in terms of delivery of genomic tests, that comes via the Genomic Laboratory Hub. We've had a number of both local and national transformation projects aiming to establish genomic testing within NHS services, and that together with the newly created networks of excellence, which I'll also comment on, is how we aim to deliver genomics. The GMS is also made up of a number of working groups which focuses their attention on the key areas of delivery of genomics, and that includes obviously nursing and midwifery, which we're going to hear about today, medical and rare disease, pharmacy, research and innovation, cancer, informatics and digital, comms and PPV, education and training. So a very, very diverse number of working groups, and they all report into an executive board, which is chaired by one of our regional chief execs. But not only do they then report to NHS England, what we're also aware of is that there are a number of other strategic partners that are involved in delivery, including industry, academia, the Cancer Alliance's primary care, for example. Next slide, please. And key to a lot of our work is our patient and public voice panel, chaired by Chris Hind and co-chaired by Eddie Blair. And the PPV panel consists of representatives from across the East of England and East Midlands, and they bring a range of their own experiences of genetic conditions and genetic testing and their own established networks. And they are key to the delivery and co-design a lot of the work that we carry out. Next slide, please. And just to sort of wrap up in the next few slides, we are now working to develop and implement a series of genomic networks of excellence, and they are going to be picking up key themes with the aim in the next 2 years of allowing the rapid translation of early research development findings into NHS clinical practice to improve outcomes. And they include the prenatal genomic network of excellence, a number of cancer networks of excellence, rare and inherited disease, cardiovascular disease, but also artificial intelligence, pharmacogenomics, and the genomics infectious disease. So covering a very, very broad range of areas. Next slide, please. And I can't list all of our strategic partners, but here are some. But if you are attending today and represent some of these partners or potentially new partners, then please do get in touch, because it's key to the delivery of genomics that we hear and see everybody represented across our GMS. And please contact us via the East Genomics website for further information and resources. And we've got a number of those available that you'll see being demonstrated here. We have quite a number of contact events, the like of which that you're participating in today. And you can also sign up to receive our newsletters and updates. And also another link there to see, again, the wide range of genomics related links on our website.
So I have the task of MC today, and so my name is Emmanuel, and we're the Strategy Director for East GMSA. And our first speaker of the day is Donna Kirwan, lead clinical midwife for genomics at NHS England, with the talk, how is genomics impacting prenatal and paediatrics? Welcome, Donna.
Hello, thank you. Thank you, Emmanuel. Thank you for introducing me. And hello, everyone. Good morning. So today's presentation is not to talk specifically about clinical care pathways or testing per se. I was asked by the team to talk about and focus on genomic networks of excellence, the National Genomic Test Directory, and some other work that's happening in the nursing and midwifery space. Next slide, please. So, without a doubt, and we cannot dispute, that genomics is changing at the speed of light. Exponential technologies like genomics, AI and robotics are creating new ways of delivering healthcare. They are transforming and revolutionising the NHS as we speak. On this day and going forward, there is one distinctive thing that gives us great advance, and that is your creativity. Today, we'll hear about that creativity in this showcase. I would like to thank the East of England GMSA for inviting me to share with you other areas where genomics is and will impact on prenatal and neonatal care that will require your collaboration going forward. I believe that everyone in this room has a role to play, and with your input, we can move forward. Next slide, please. Next. Okay. So in my talk, I'm going to cover these three areas: prenatal genomic networks of excellence, National Genomic Test Directory, the nursing and midwifery genomics framework. Next slide, please. The Prenatal Genomics Network of Excellence is one of several ambitions cited in the NHS Genomics Strategy, and the aim is to ensure equity of access to high-quality pre- and perinatal genomic medicine for all families across England, capitalising on new technological developments to deliver high-quality testing for more conditions. And it's going to maximise the impact of the NHS GMS alliances to transform NHS services going through, both driving clinical change and alignment with research and innovation endeavours more broadly to create the evidence base and the models of adoption to support rapid uptake within the NHS GMS and to inform commissioning decisions and responsibilities. The network will bring together partnership, unification of various NHS genomic services, universities, NIHR, the academic health sciences networks, non-profit organisations and industry to accelerate genomics across the country to benefit current and future generations. Now, all NHS genomic networks of excellence have now launched and will complete in 2 years. Several are starting to deliver on their work plans, like the Prenatal Genomic Network of Excellence. The inaugural meeting of all GMS, Genomic Networks of Excellence, has reviewed the work packages proposed in their initial business plans, along with the timeframe for delivery. And as the GU lead for the Prenatal Genomic Networks of Excellence, I am the conduit for NHS England, where I'll be supporting the stakeholders involved, aiding communication and escalating progress and concerns with regular meetings and quarterly GU SMT assurance meetings. So here's a quick overview of the 3 work packages involved in the Prenatal Genomic Networks of Excellence. Work Package 1, led by North Thames, Central and South, and patient and public involvement. Work Package 2, again, North Thames, Central and South, patient and public involvement. And Work Package 3, which is led by North Eastern Yorkshire. Now, regarding Work Package 1 and Work Package 2, that is essentially led by Professor Dame Lynn Chitty, and I have oversight of those groups, but not directly involved with the outcomes, with the deliverables and outcomes from that. But Work Package 3, I will be very involved and working very closely with the North Eastern Yorkshire team. So let's just focus in and have a closer look at Work Package 1, the expansion of the fetal prenatal services to deliver more non-invasive prenatal testing to reduce the need for invasive testing and associated risks. So these are some of the key aims in that work package, and this list is not exhaustive, but I've picked out what's really relevant at this time. And it's expected that this work stream will develop more tests for monogenic conditions, aligning with some ongoing projects that are based in GOSH, NIHR as well, and build on the North Thames GMSA audit of prenatal testing to identify gaps in NIPD delivery, to identify education engagement needs in collaboration with other GMSAs and GLHs. Sustainability will be delivered through incorporation of new tests in the National Genomic Test Directory and embedding education in appropriate pathways, training and CPD. Work Package 2 focused on developing the evidence to expand the eligibility criteria for fetal testing to focus on conditions with ramifications for neonatal management and exploring the ethics of incidental findings from parents, including feedback results to patients. And as you can see here again, these are some quite high level aims that have come from the business case that was put forward. In current prenatal testing for monogenic conditions, it's largely based around single gene testing in known high-risk families and exome sequencing in fetuses with sonographic abnormalities by trio analysis of panels of genes known to cause fetal or neonatal structural anomalies. So R21 is delivered from North Thames, Central and South GLHs and results in a diagnostic yield of around 30% over traditional diagnostic approaches. And obviously the aim of this work package is to, look at shine a light on the R21 pathway, which I know you've been very wedded to in East of England and done a fantastic piece of work, which I know is going to be discussed later. But obviously there is more to be done with the rest of the country. Now this one focuses on considerable variation in care pathways across the country and often poor access of ethnic and other underserved populations to maternity care and pre and perinatal genomic testing. And it builds on the work of the local transformation project that was undertaken a couple of years ago in northeastern Yorkshire. And we know from the literature and other national projects, the GMSA project in northeastern Yorkshire and data collected in NIHR funded and the Funded Express project, that there is considerable variation in care pathways across the country and often poor access of ethnic and other underserved populations to maternity care and also pre and perinatal genomic testing. So all 7 NHS England GMSA boards will be approached to participate in the prenatal genomic networks of excellence. For each GMSA, we will engage with fetal medicine units, regional clinical genetic services, regional obstetric and midwifery leads, and local trust-based prenatal services, including neonatal services, where necessary. So now over to the National Genomic Test Directory. Now you heard a little bit about this from Dick before, and I know that most people on this call will be very familiar with this, but I'm just going to tell you about some work that's going on nationally with NHS England. The National Genomic Test Directory is a foundational block to the whole service and needs investment to allow for the effective mainstreaming or genomic testing in the NHS England. The directory consists of 2 spreadsheets containing more than over 2,200 genomic tests split between rare disease and cancer. And it was updated in January 2024 to include updates from 2023-24 application round. And a further updated test directory will be published this month. The most recent application cycle closed on the 1st of April for implementation from April 2025, but applications will be reviewed by the test evaluation working groups for cancer, rare disease and pharmacogenomics over June and July, and followed by an impact assessment with the NHS GLHs. NHS England assurance and governance approvals take place in November, and applications that meet the fast track criteria will continue to be considered at any point throughout the annual process. Now, this section describes examples where the current test directory's description of genomic tests does not support identifying appropriate tests. So, for example, on this slide, you can see microarray testing. Every lab performs the same assay. There are 21 rows in the rare disease covering microarray. Panel app has panels for 12 of these clinical indications with microarray testing, despite microarray assay not being sufficient resolution to analyse variants within specific genes. Microarray is listed multiple times to inform clinicians and labs that for the clinical indication in context, it is necessary to perform an array either on its own or in combination with another test. By only making a single microarray test in the National Genomic Test Directory could result in other appropriate tests not being performed, or inappropriately doing an array when a different test would have been better. And I know that generally this is, everybody's frustration in the clinical setting. Next slide. So what are our aspirations? So our aspirations are to make the GMS more interoperable with defined standards and data sets, to improve searchability, to improve test order quality through correct test selection and sample requirements, to improve the ability to manage new genomic tests and amendments to tests, to interface with digital resources, for example, genotes. And the proposed solution is to move away from the current model and provide a suite of digital services, a series of repositories, a content management system, a set of systems, application programming interfaces, an online accessible portal to allow users to interact with the reference data. So from March to July this year, a discovery phase project was undertaken, which generated rich information, and from this they garnered 50 interviews and just over 300 survey results. And out of this, there's been a position paper written which has gone to senior management team. Option 1, do nothing. Option 2, adapt the structural and process change to the National Genomic Test Directory. And option 3, aim for a digital genomic test directory service. So there's been further direction to accelerate the development of the test directory with the first iteration to be produced by June 2025. The long-term ambition is a unified genomic record to provide a single access point for patients and their clinicians to a per patient genomic record and relevant linked data. Now moving over to nursing and midwifery. And this quote, which has come from the distant past, I suppose, in 2011, it was a policy paper, Genetics and Genomics in Nursing and Midwifery, stated that nurses and midwives accept the changes brought to healthcare by genomics as passive agents, or they can be proactive in shaping and informing the transformation in their areas of practice. And without a doubt, we can't dispute that that has been evident since we came into play as GMSAs. So the midwifery workforce alone, and this is an inflated figure because there was a shortfall, and now with recruitment, things have improved. We are now up to 23,400 midwives. And what we need to do is to continue to connect and interact with the workforce. We are the largest professional group with nurses in the healthcare system, and we play a crucial role in getting genomics integrated into maternity and neonatal services. We've been engaging and connecting with our midwifery colleagues for some time now, and there's still much more ground to cover. Our ambition is to develop a future nursing and midwifery framework to enable a coordinated and standardised approach for genomics going forward. So here you will see a schema of what's been happening in the background regarding development, the framework. We are in a draft stage, but this is an ideal opportunity to corral everyone, not just GMSA, nursing and midwifery leads, but also programme managers, educators. We're also going to involve Team CNO, Team Mido, to help this framework get from a now state to a future state. So it's got to be collaborative. And the success of this framework relies on input from everyone. The framework hopefully will offer guiding principles and essential activities to prepare the nursing and midwifery workforce to implement equitable access to high quality genomic services for individuals with rare conditions and cancer. I do like quotes. I look at quotes from various books and I like to get beneath that quote and interpret it from my perspective and the perspective of my professional self of what's happening in terms of genomics in this case. And this quote is from Lewis Carroll's Alice in Wonderland. How nice it would be if we could only get through into Looking Glass House. I'm sure it's got, oh, such beautiful things in it. And just as Alice imagines a wondrous world beyond the mirror, healthcare professionals like us here today see genomic as the realm, as full of promise for revolutionary medical breakthroughs. This includes personalised treatments, early disease detection and new therapies, symbolising the beautiful and transformative possibilities that genomics can bring to medicine. Thank you.
Thank you, Donna. Really informative, and looking forward to hearing more about the networks of excellence as they develop and the role that we can play in the East. As Dick mentioned earlier, one of our guiding principles as an alliance is equity of access. We're going to hear from 2 local projects that have been delivered within the East. And we'll hear from Dr. Kasia Gajewska-Knapik, who's a prenatal care lead for genomic services, East Genomics, and consultant in obstetrics and fetal maternal medicine, a subspecialist at Cambridge University Hospitals. We'll also hear from Lauren Capacchione, project midwife with the East GMSA, and we'll hear from Beth Evans and Nicola Young, specialist midwives for monogenic diabetes, East GMSA. And they'll be telling us about R21, which is the rapid prenatal exome sequencing test that you've just heard about, and monogenic diabetes and pregnancy.
We were asked to present the project which we undertook within East GMSA, and I will start with some introduction, and then Lauren will talk in details about the output of the project. May I have a first slide, please? So we were very much interested in how the access for patients is for R21. And as a first step, we decided to look at what actually is a provision for this testing within the region which covers East GMSA. If we think about current patient journey, patient who is diagnosed with structural differences, this usually happens during the scan, sometimes earlier in the pregnancy, but for the vast majority of patients at around 20 weeks. Then we offer invasive testing, which after 20 weeks would be mainly amniocentesis. At this point, we send the material for testing, and after this testing, we do get the result as confirmation or not of genetic problem. And then we form MDT and discussion amongst the professionals and discussion with the patient regarding further management. Sometimes it is the decision is about termination of pregnancy, and we need to think about the specific circumstances in pregnancy. We have got quite severe time constraints here. If we think that majority of problems are diagnosed at around 20 weeks, then we have very short period to deliver diagnosis. And very often there are several points which can slow down our delivery of the result. Being constraints within the test itself, which require particular time for the test to be completed, not mentioning about the logistics for the patient to, for example, attend for the test or be referred from the local hospital to regional center. And the current pathway for the fetus with structural abnormalities is that if the patient would like invasive testing, then in first instance the material is sent for QF-PCR, which tests for common aneuploidies, and they will be responsible for about 30% they will explain about 30% of abnormal findings on the scan. We used to send for karyotype. These days we send for karyotypes only in particular cases. Majority of cases, if the QF-PCR comes back as negative, as normal, we send for chromosomal microarray, which looks for chunks of DNA missing or additional chunks of DNA in baby's genetic material, and additional yield of this is about 6%. For particular indications, If chromosomal microarray is negative, we send for rapid prenatal exome sequencing. Sometimes we send for it in parallel to chromosomal microarray for time saving. Rapid prenatal exome sequencing is looking at misspelling mistakes, single nucleotide variants, and additional diagnostic yield is between 6 and 80%. For rapid prenatal exome sequencing, there are certain inclusion criteria, as it does not report all the results. It reports only results which are in line with abnormalities which were found. And multiple abnormalities are one of the criteria. Most of brain abnormalities, most of skeletal abnormalities or renal abnormalities are indications for R21. There are obviously also exclusion criteria, and some important considerations here are regarding termination of pregnancy. So if termination of pregnancy has already been decided, then R21 is not provided. If fetal demise occurred, or fetal demise is imminent. So the R21 is for patients who would like to continue with the pregnancy, and when the result can influence the fate of the pregnancy. Very important is that we aim to test the fetus and the parents. Trio analysis gives the best diagnostic yield and the lowest amount of VUSs. Sometimes trio analysis is not possible, in which case we can do duo analysis. There will be occasional cases when we cannot provide duo analysis as well, and then we provide single analysis. However, number of VUSs is quite high here because we can't compare the material with a material of the parents. And the proband-only situation might, for example, be in cases when we have egg and sperm donation. We've identified the team of enthusiastic colleagues who took on the project to understand delivery of equity in fetal medicine, how it looks like in our region. And at first point, we concentrated on what is the provision of particular places in our region and what we can offer. So we sent the questionnaire, which included training, some baseline data, team structure, patient and family support, and stakeholders engagement. We send it to all units which provide care, including ultrasound care and fetal medicine care. So there were tertiary centers, district hospitals which had fetal medicine provision, district hospitals which did not have fetal medicine provision. And also we have one place where the care is provided by tertiary outreach. The whole region sends samples to GOSH. And with regards to the outcomes, I will ask Lauren to provide that for us. Thank you.
Hi everyone, so I'm going to take you through the findings and the outputs from the project. I think trying to keep the time, I'll go a little bit swiftly through this, so apologies. If you want further details, please do get in contact with me personally. You can go through it. Next slide, please. So the key summary of findings was there was a wide variance in service delivery from team composition, time allocated for appointments, how busy the units were, differences in the MDT approaches and how they were consenting for R21. There was issues with data collection for R21, so it was quite challenging to get the data that we requested because actually there's no formal process for collecting data that's been established. So that was really key to us finding out the results and being able to interpret the data. It was obvious from the surveys that there was a requirement for more educational resources that are specific to R21, because there wasn't anything there that clinicians could access easily, which was specific to that, and that there was a lack of user feedback within fetal medicine units. There was only 2 units that had any form of specific patient feedback. And also there was a need for resources to help the teams deliver that equitable service. So we were looking into how we could support teams to be able to utilise that inclusion and exclusion criteria for the R21. So our project outputs, next slide. So you've seen this already. This is our inclusion criteria, and on the back it also has the exclusion criteria, which is a poster that goes into the clinic so that the clinicians can triage cases as they're seeing them, just to have a check to see whether or not they would need to start thinking about having an R21. So it's really that just-in-time resource for clinicians to be able to use to bring in that test directory into the clinical room. And we've also got a pathway checklist, a document just to help the workflow as you take a sample, and all the different steps that you need to go through to ensure that that sample is taken, the consent is done properly, and liaising with the lab. It's quite a drawn out process, and so there's lots of points along that way where things could maybe get delayed. So what we want to do is for it to be timely. So we've devised this so that each patient they can work through to make sure that they've done the steps that are required. And also we had a spreadsheet for data collection because there wasn't any organised way that fetal medicine units were collecting their data on R21. So we devised a one-stop kind of spreadsheet for any prenatal testing that they're doing, so that they can then have that, and it generates quarterly numbers and things, so they can just pull that off. So in future, if we want to interrogate R21s, we should be able to do that with ease. And we did a trial of collecting patient feedback. So we got the Rosie and also East and North Hearts, who are trialing a very basic form of how people are finding the appointments and fetal medicine services, just to start the process of asking the question to get the feedback, because at the moment they didn't have any feedback. So that was just to start that process and hopefully evaluate that at some point. We did bite-sized learning, which was attended by over 80 people, which is really good. We now have an East Prenatal Genomics Forum, which Joe Hargrave will talk about in further depth, but that's just to support collaborative working in the East region with a genomic focus in fetal medicine. And we've got hopefully soon R21 e-learning that we've developed that hopefully should be launching soon. And as soon as it is, we will send around comms about that so people can access it. So in summary, in our region, there was really good evidence of practice within our region. The challenges of inequity are the issues that we have about data collection and there not being any KPIs linked to the R21 currently. Different provisions within clinic times meant that patients had a different amount of time with the specialist, which affect equity. So it's highlighting that to the teams so that we can all learn from each other, because we share these results with the fetal medicine teams within the East. They could see that Nottingham are doing this and Brooks are doing this, and they can then go back to their service providers and discuss whether or not they want to change how they provide care. Staffing composition, again, there's quite a few differences within that. So it's highlighting those differences and making everybody aware of what everybody's doing so we can learn what best practice looks like, and then capturing patient feedback so that we can really see what the patients need by hearing the patient voice. So recommendations: using a standardised approach for capturing fetal medicine services activity, utilising the available tools to improve the referral uptake in secondary and fetal medicine services, having that e-learning available so we can improve knowledge and skills and understanding as new people come into fetal medicine as well. Encourage units to trial patient feedback is something that we need to do a little bit more work on. And then also just thinking about the other pathways that are involved in fetal medicine, which are 27 are 412, which I can't go into due to time. So next steps. So we are working and almost finished the clinical pathway initiative. There the tools that we have developed are also being looked at in other GMSAs and adapted, hopefully, to be used in their areas. Oh, that's the end. There was another slide that I think we were hoping to put in, which was we did have a poster at the BFMS, which showed all the work that we've been doing, and I want to thank the teams that helped support to generate that. I think that's the end. Is there another slide?
Thank you, Lauren. Over to Beth and Nicola.
Thank you. Good morning, everyone, and thanks for the opportunity to speak to you today. So my colleague Beth and I are specialist midwives for monogenic diabetes, and we are working with a team at East GMSA. And we wanted to talk to you today about gestational diabetes, not always what it seems. I think Beth's, have you got the slides, control of the slides, Beth?
Yes, I have.
Yeah, fantastic. Thank you. So gestational diabetes is high blood glucose, which is first identified during pregnancy, and this usually resolves following delivery. However, up to 50% of women diagnosed with gestational diabetes go on to develop type 2 diabetes within the following 5 years, and they have an increased lifetime chance of developing type 2 diabetes beyond that. Every year in England, approximately 700,000 women give birth, and out of those women, around 30,000 are thought to have gestational diabetes.
Although gestational diabetes will be the correct diagnosis for the majority of these women, it's not always the case. Around 1 to 2% of women initially diagnosed with gestational diabetes will actually have glucokinase hyperglycemia. Glucokinase hyperglycemia is a genetic variation in the glucokinase gene. It has a strong family history due to the autosomal dominant inheritance pattern. When glucokinase is functioning normally, it acts as a glucose sensor for the pancreas. So people with glucokinase hyperglycemia have a mildly raised fasting blood glucose, which has been present from birth. Although glucokinase hyperglycemia falls under a subtype of monogenic diabetes, people with glucokinase hyperglycemia are not diabetic. And it can be better described as non-diabetic hyperglycemia. Glucokinase hyperglycemia is not known to cause any long-term health complications, and outside of pregnancy doesn't require any treatment or monitoring. People with glucokinase hyperglycemia are also not at an increased risk of developing type 2 diabetes.
So in terms of the testing criteria, obviously Donna touched on this in her earlier presentation. So as she said, the National Test Directory outlines the full range of genomic tests that are commissioned for England and standardises the criteria for testing. So just the criteria for testing for glucokinase hyperglycemia is very simple. It's that the woman has been diagnosed with gestational diabetes in her current pregnancy, that her fasting blood glucose, whether that's from an oral glucose tolerance test or home blood glucose profiles, is raised, as Beth's mentioned, so generally between 5.5 to 8. And the BMI is also part of the criteria, so relatively slim. So a BMI of less than 30 in women who are white, and a BMI of less than 27 in women who are from a ethnicity where there's a high prevalence of type 2 diabetes. So this isn't a new test, but it's currently not being offered in an equitable fashion, which again, Lauren's referred to, and Donna touched on earlier, that this is, a key aspect of the national strategy is equity in testing.
So as patients are diagnosed with gestational diabetes, they will enter the established pathway for gestational diabetes. And it's at this key touch point that we would really ideally assess people's eligibility for testing, as Nicola mentioned, with the criteria. So as people enter the pathway, it's then reviewed what's their fasting blood glucose and what's their BMI. For the majority of patients with gestational diabetes, they won't be eligible for testing, but for a small proportion, they will be eligible for testing. So testing can then be offered if it's appropriate. For people without a GCK gene variant, the GDM pathway will continue. However, when we do correctly diagnose glucokinase hyperglycemia, so a GCK variant is identified, women will exit the gestational diabetes pathway, and we can then offer them non-invasive prenatal diagnosis.
So as we've said, outside of pregnancy, people with glucokinase hyperglycemia do not require treatment. However, it's during pregnancy the fetal genotype is the key factor in determining the management options. And the fetal genotype is determined via non-invasive prenatal diagnosis. So you could have the scenario where the woman has been identified as having that gene change and she accepts NIPD testing, and her fetus is also diagnosed as having the same gene change. The baby is then at no increased risk of macrosomia and no treatment is required because, as Beth, we were discussing earlier, she doesn't actually have diabetes. The next possibility is that the woman has been diagnosed with that gene change and the fetal genotype is unknown, and that could be for a variety of reasons. It could be because the patient's declined the test. It could be because it wasn't possible to obtain the test because the woman was diagnosed too late in pregnancy, or the paternal sample wasn't available for the NIPD, and for whatever reason, or multiple pregnancy, you know, and so on. So for whatever reason that the fetal genotype is unknown, there's an unknown risk of macrosomia, and therefore treatment and management of the pregnancy will be based on the, you know, the normal serial growth ultrasounds that women would have when they have gestational diabetes. And then the third possibility is the woman has the gene change and her fetus is also as diagnosed as not having inherited the same gene change. So in this situation, the baby is at an increased risk of macrosomia, and consideration would need to be made as to the timing of birth and judicious use of insulin.
So our project to date has been to introduce and embed genetic testing for glucokinase hyperglycemia within the existing pathway of for gestational diabetes. We have been scoping the current knowledge and testing practice within the region, particularly working with the diabetes maternity teams through engagement sessions and individual meetings so that we can assess what their level of knowledge is and their current testing practice. We've identified that there was a gap in resources to support both patients and the maternity diabetes teams. So we've developed patient information leaflets, and we will be launching an e-learning module, hopefully by September, which will be hosted on the NHS Learning Hub and will be free for all healthcare professionals to access. We will be evaluating the patient experience through development of a patient feedback questionnaire to see how patients and their family feel about the offer of genetic testing within this pathway.
So our next step is we are hosting a midpoint project update next week on Wednesday via Teams, and that's aimed at maternity diabetes service leads in the region to look at what they feel might be the challenges in embedding this testing within the region. And obviously, if anybody is interested and would like to join that meeting, then they can just email us and let us know, or use the QR code if you can use that with your phone now on the screen. Next slide, Beth. And thank you for listening. And if anyone wants to contact us for any further information or to join the meeting next week, then please email us at the email address on screen. Thank you.
The next set of speakers will be covering the Generation Study, which is the groundbreaking research study which will sequence the genomes of 100,000 newborn babies. So to present that, to present more about the project, welcome Dr. Meekai, Clinical Fellow in Genomics, Newborn Screening at Genomics England. welcome Rebecca Middleton, who's a public and patient voice panelist at East GMSA, and welcome Joe Hargrave, who's our midwifery lead at East GMSA.
So thank you for the invitation to speak about the study. I'm sure there are quite a lot of you in the audience who are already quite familiar with the programme and maybe already actively involved with it. But for those of you that don't know much about it, I'm going to really give you a fairly speedy overview of the background, the design and the evaluation of the study. We just have 10 minutes, so forgive me if I'm speaking quite quickly. So basically, the Generation Study is an ethics-approved research programme which is aiming to undertake whole genome sequencing in 100,000 newborns at birth to screen for 208 current treatable genetic conditions, which have been through a fairly rigorous process of selection. And I'll tell you a little bit more about that in future slides. So the programme has really three main aims. The first one, and the one we're really dealing with right now, is the evaluation of the clinical utility and the likelihood that this test will, by prompting intervention, result in improved health outcome. And we want to look at the feasibility of the routine whole genome sequencing in newborns in the NHS. The second part of the study is about discovery research. So data that's generated from this study will go into the National Genomic Research Library, and we hope that this will be made available for research with a focus on development of new treatments and diagnostics for NHS patients. And the third part of the study is a really bit more speculative, and we're really trying to explore this in more detail at the moment, but it's to consider the potential use of storing the individual's genome across their lifetime. And as I said, this is really very much in the exploratory phase, and we're currently engaging with our public standing groups on thinking about how we could do this in greater depth in the future. So just a little bit about how we work. So we have a number of core in-house teams, and each of these teams is focusing on very specific aspects of the study, such as the selection of the conditions, the recruitment, ethics, and so on. And then, as many of you will know, we have a number of groups where we're working with external stakeholders, such as the NHS Strategic Implementation Group, who've helped us with supporting the design of the study, and they communicate the expectations of it. The NHS England Clinical Assurance Group, who help us support us in the selection of the genes and conditions for inclusion. And then we've had a very important engagement programme where we've had a lot of public and participant involvement, and they've been involved in many different areas of the study. And you'll hear a little bit more about this from Rebecca later in this session. So if we just step back to reflect for a moment, where are we right now with newborn screening? And as many of you know, we currently have an extremely successful newborn blood spot programme in the NHS, where babies have a heel prick test at around day 5 of life. This is a really well accepted test with an uptake rate of 97%. But as you know, there are just 9 conditions on the newborn blood spot screening programme. And when we compare this to sort of international counterparts, we in the UK are really screening for way many treatable genetic conditions than other countries. And there may be different numbers of reasons for this, but essentially we're very much lower than most of our international counterparts. So with this study, we're not aiming to replace what is a very successful programme, but what we're hoping to do is potentially enhance it by taking a slightly broader approach. So as I mentioned, in our current newborn blood spot programme, we've got 9 conditions that we screen for, but in fact, there are very many more treatable genetic conditions that are not being looked for. And many people believe that genetic diseases are not treatable, but if we just take a quick look at OMIM, we can see that around 15% of the over 4,000 genes that are associated with phenotype causing variants have a treatment that's directed against the disease mechanism. Of course, not all of these may be suitable for inclusion in the newborns programme. For example, they could be adult onset conditions or have a treatment which is not available in the NHS. But for sure, there are likely to be more than just 9 conditions which could be screened for and could be treated. So just thinking about these numbers, a conservative estimate is that of the almost 700,000 live births in the UK, around 1 in 190 are likely to be born with a treatable genetic condition. That's 9 babies born every day in the UK. And whilst each of the individual conditions may be very rare, as it's often quoted, rare disease are actually very common when you take into consideration their collective impact. So our aim is to try to identify as many of these 9 cases that have a treatable condition, and based on some modelling we've done from the study, we expect around 1,000 screen positive results from the 100,000 newborns that will undergo screening in the study. So how are we implementing this? We're looking at recruiting NHS sites throughout England. I know that there are many sites already looking at coming on board, and you've got sites already up and running in Cambridge. But we're taking a rather sort of staggered approach to starting cautiously, making sure all our processes are working. So we're starting sort of with 3 to 5 trusts. As I said, we've got 3 sites live and recruiting at the moment, and several others close to opening. And the plan is to really just bring those sites on board in a sort of stage fashion. What kind of factors we consider when looking at different sites to take part? We look at birth volumes, we look at the diversity of the people who are using the hospitals. We want to, again, have a diverse representation, and then some various sort of maternity department performance indicators. So who can take part? Well, obviously you need to be pregnant, you need to be more than 16 years old and have an NHS number, and you need to have a registered GP in England. We're at the moment only recruiting singleton pregnancies, and they must be not a surrogate or planning to give up a baby for adoption. The sample that we'll take is a cord blood sample taken on the first day of life. But if this isn't possible, it could be there's an emergency and we can't get a blood sample, or for whatever reason, then there is the option of a secondary sample, which will be a heel prick, which can be taken for up to 28 days after birth. There are babies on special care or NICU who've got indwelling lines and have consented to take part in the study. The sample can also be taken from there if it's clinically appropriate. So women that consent to join the study, it's important to understand it's an all-in offer, which means that they will be asked to sign up for the whole study. This means a number of things, that their baby's genome and data will be used for the following things. Firstly, the return of actionable results, as I've already discussed. For the research on newborn screening and potentially broader healthcare questions, as I talked about data going into the NGRL. We'll be asking them to consent to being recontacted to ask for follow-up data relating to the programme, or potentially to take part in future studies. And it's important to say here that because all these are babies that are being recruited, that when they get to 16, the plan is that they will be reconsented themselves if they want to remain in the study. And then finally, we just want permission to use any of the leftover sample for further research. So this is a kind of high-level view of what the participant experience will look like. So research midwives will start speaking to women in the mid-trimester of pregnancy after the 20-week scan. They'll get signposted to resources which have been specifically designed for the programme and which have been developed after a substantial amount of patient and public engagement and input. The parents get time to consider whether they wish to take part, and then they can be consented by telephone. We hope to get the sample at birth, and initially it might take up to 2 months to get the results, but as the recruitment increases and we have larger numbers, we're aiming for this to come down to 2 weeks in turnaround time. And if we have a condition suspected result, this will be coordinated through a network of specially appointed regional results coordinators who will liaise with named specialists for that condition. And this has to be someone who has in-depth knowledge of the condition. And I'll speak a little bit more about pathways following a condition suspected result in my later slides. But we do hope to keep in touch with the families at regular intervals as we evaluate the programme. And importantly, participants have the option to withdraw at any stage. Okay, so the challenge when choosing conditions is, as I showed you from the previous slide, there are actually hundreds of them. So how do we start? We don't want to look for all of them for a number of reasons. And we know that we have the Wilson and Younger principles, which are those that we traditionally use to guide us when we're thinking about screening programmes. But in this context, those criteria are extremely challenging because the disease is so individually rare. And so we've taken a rather more bespoke approach in the context of introducing a UK-based programme being carried out in the NHS. And we set up a conditions working group who helped us to establish some principles against which we could evaluate the various genes and conditions to decide how and whether they should be included in the programme. I'll just briefly talk you through the 4 core principles. The first one relates to the fact that there needs to be good evidence that the genetic variant causes the disease, that they're linked, and that it can be reliably detected using the technology we're using, which is short read sequencing. And where appropriate, we want a non-genetic confirmatory test, so that when the patient, because the patient doesn't have a phenotype, so we'll be getting a genetic result, and obviously to determine whether this is a true positive, we would like to have a non-genetic confirmatory test available. The second principle relates to penetrance and the fact that we want a high proportion of individuals with the variant to then manifest symptoms of the disease, and these need to be symptoms which are significant and debilitating. The third principle relates to intervention, that there should be an intervention which is likely, if it's given early, to lead to substantially improved outcomes compared to if it's given after the onset of symptoms. And the final The final criteria relates to the fact that the interventions need to be accessible within an equitable manner within the NHS, so available to all. So during the initial phase of the programme, we looked at 834 genes, selected 462 against the principles, which represents 208 conditions, since more than one gene can cause the same condition. And the full list of these genes and conditions is available on our website if you're interested. I want to stress that the study is only looking for a very specific set of conditions, genes and variants. People always worry about us picking up VUSs and things that we don't know how to interpret, but that's not going to be the case. We're looking at a very specific set that we will have defined before the programme begins. Also to say that this is an iterative process, and so the list is not completely set in stone, and it's entirely possible that some genes will be removed or added as we accumulate more evidence and knowledge as the programme progresses. So what happens once a result is a positive result is found through screening? So I mentioned earlier that results will go to the regional results coordinators in each GMSA, and they have a pre-populated list of specialists who have agreed to be contacted and who will make the phone call to the parents to give the result. They arrange the confirmatory testing and the onwards clinical management. And we, as I said before, we're expecting around 1,000 positive cases. So if you think about the conditions, I said there are 208 conditions. Some of them are extremely rare. So not all conditions are going to be represented in this study. We may not find a case of any of them. And each condition, if it is found, is likely to have very few cases. So we don't anticipate it posing a major burden to any individual service. Just a note really on the confirmatory testing and referral pathways. This has been with the involvement of many people, both inside and outside of GEL, and we've developed some confirmatory testing pathways for each condition. They're pretty high level, condition specific, location agnostic guidance, which includes the urgency of review, the type of confirmatory testing, and a general sort of brief outline of the management. And these have all been developed and signed off with collaboration from the relevant CRGs and CAGs. And as I mentioned, we've also worked quite closely with the commissioning teams and the GMSAs to try to map each condition to the appropriate NHS clinical service that will be responsible for the child and the family and their ongoing care within the NHS. So very briefly on the evaluation side of things, I'm not going to go into too much detail about this, except to say that we're not really just focused on the clinical utility, but we also want to ask the participants and other stakeholders, do you think this is a good idea? Is it feasible at scale? Is it cost effective for the NHS? And is it fair and equitable? And we actually have an external evaluator who's undertaking this detailed piece of work so that we're not looking like we're marking our own homework. So by the end of the study, we hope very much to have sequenced the genomes of up to 100,000 newborns from across England. We hope to establish an evidence base on what the screening of those babies means for future treatment and research with newborns, and provided the data that's needed to evaluate the research study's outcomes and to inform any future policy on newborn screening. Thank you very much.
Thank you, and I will pick up the baton from here. Hello everybody, my name is Rebecca Middleton. Next slide if that's okay. I'm a rare condition patient and a mum, a mum of two, and I have a diagnosis of familial brain aneurysm syndrome, a condition that killed my grandmother at an early age and my mother and caused me to have brain surgery around about 6 years ago. I was recruited onto the 100,000 Genomes project back in 2015 along with my father, and I'm still awaiting a result from that. I'm a founding member of the participant panel at Genomics England and its former vice chair for rare conditions, stepping down only last month as my term came to an end. And I'm delighted to be also a member of the East GMSA PPV panel and the East GMSA Generation Study Working Group, as well as a member of the NHS Strategic Implementation Group. And I'm also the founder of Hereditary Brain Aneurysm Support, a charity, a UK first charity that supports families like mine. So my involvement with the research started back with a public dialogue that began in September 2020. It looked at the public views on the implications of whole genome sequencing within the NHS context. And there were several key findings there, with the public broadly supportive of newborn research, but they did also call for transparency, ongoing public involvement, and the need for it to be resourced and those parents supported all the way through the journey. As the dialogue evolved into a research study, and with my knowledge of the context and my experience that I had built up over time, as my experience as a rare condition parent as well, I became chair of the recruitment working group, which is made up of a cross-section of patients, clinicians and midwives and community specialists, and we looked at the journey of recruitment and consent with parents and clinicians, discussing all elements of that journey, and I'll come on to that a bit later as well. And I've also been recently asked to be on the recruitment community of best practice group, which I'll be joining in the summer, and I'm also, as it says there, a member of the NHS strategic implementation group. Why is it so important to start with a patient? Well, as it says there, a world first project needs a world first journey in co-production. And I'm sure I'm absolutely preaching to the converted here, but a reminder that genomics is the science of people. So it's essential that the patients and their lived experience is at the heart of this landmark study. And involving the patient experience early has been critical in ensuring that the delivery of care is centred around unique needs and preferences and perspectives of individuals. And from personal experience, I know why. A delivery of a result and indeed a conversation around consent about taking part in a world first study are two key moments that certainly I will stay with me for a long time. I was consented onto the 100,000 Genome Project, and I remember that experience vividly. I remember being presented with a form that was akin to War and Peace. I'm glad to say that the Generation Study consent form is a lot easier to understand. But I also was lucky that I had a consultant who helped manage my expectations. And we know that that's really critical in this programme too, that management of expectation of what this project is and what this project isn't. So we've learned, we've taken our time to learn from families' experience from the 100,000 Genome Project, but also other studies. And we know that it's really critical that perception does match reality. And that's essential to build trust as we take patients and parents with us on this journey. This project presents a different scenario, though, from the 100,000 Genome Project. I had a need, this is an option. However, those principles of ensuring that we allow space and time and translation and playback, that we present easy to understand materials for parents, is absolutely essential part of the recruitment process. So putting patients at the heart of this research project also ensures we're paving the way for a better journey for everybody involved. And the design of the patient journey, how samples are taken, how results are shared, they've all been delivered with parents, for parents, as well as together with NHS staff, patient representatives with crucial lived experience of what it feels like to have their baby diagnosed, and specialist stakeholders have all been captured, and there have been challenges captured too. So we are being robust in our approach. And the aim has been to create an inclusive journey for all types of parents, while as much as possible reducing the burden on the NHS staff as well. So as I say, it was essential that we looked at that lived and those real life concerns, but of course there's still a lot of unknown out there, and as this project goes live, we are sure there will be different questions and different issues that come up. So it is an iterative process. And of course, one of the biggest unknowns, of course, for the parents is a diagnosis journey for that very small percent that will get a condition suspected call. Diagnosing well babies, although indeed some may be poorly, will be absolutely a life impacting time for the parents. And these conversations will stay with the parents forever. Again, I speak from experience here from my own clinical diagnosis. And what's more, we're delivering these results when perhaps the hormones are still raging and new mothers and fathers are still trying to figure out what day it is. We've all been there. So that bridge across from Genomics England to the NHS has to be strong. This is a moment when the emotions and fears are at the highest, the knowledge for the parents perhaps is at its lowest, and the parents and the child, the baby, is perhaps at its most vulnerable. So we need to make it as okay as possible. And this is the time when expectations have to match that reality, and we lay the path to what comes ahead to get that care within the NHS going forward. So speaking to parents and those with experience and those clinicians with experience too, and those midwives, we've plotted and planned as much as we can to build the scaffolding, if you like, around the journey and offer that much needed support that the public said that we should absolutely deliver as part of the public dialogue back in 2020. So why does this scaffolding matter? Well, again, I'm sure I'm preaching to the converted here, but by building our research project from the Patient Hub, we can assure that we are building trust, and trust in genomics and trust in the process. Of course, outside of small pockets of patients and specialists, there is a general lack of knowledge about genomics, and of course it can bring a lot of assumptions and fears, and we know this because we have done the user research. And from the first time, we're moving outside of these smaller knowledge circles, and we'll be doing it at scale. Genomics previously has been the realm of people who are poorly, people like me who have an urgent need for an answer. But here we're offering the service to the well, not the worried well, but perhaps the curious well. And this comes with its, again, own baggage and perceptions that we have to manage. And of course, the experience will be new every time, with parents being asked to take part in a research project, give their consent to a diagnostic test that they perhaps have know little about, and have their data stored, which perhaps hasn't been done before. So this is going to be a new experience for the vast majority. So ensuring that we make sure that the process is designed in a way through co-production and make all those materials engaging and easy to understand as possible is absolutely crucial. And from the recruitment working group, I know the level of detail that has gone into everything, from the colours we use, the words we use, the phraseology, the images. It has all been absolutely examined and examined again. And finally, as mentioned, it is an iterative process. We are always learning, and that live feedback will help us to evolve the process and evolve the materials too. And in summary then, through co-production and listening to parents, we have mapped out the journey that we believe will need to be adapted as we continue to listen and learn to real live patient, but also midwives and clinicians' experience as well. And my final point is that we mustn't forget that there is a third aim of this project, to look at the benefits of the lifetime genome. So again, further dialogue and engagement will be needed to ensure we earn that trust and understanding. Thank you so much for your time today. Bit of a whistle-stop tour, but I hope it's been informative, and happy to take questions at the end. Thank you. And over to you, Jo.
Thank you so much, Rebecca. So you've heard from the national team, you've heard from Rebecca thinking about that patient side. So as lead midwife within the East GMSA, I really wanted to sort of just give a brief overview of what's happening in the East in terms of our role in this project, and also the progression where we've got to so far. This, in a nutshell, is where the GMSAs are responsible for some deliverables, and we've been provided with some funding to carry out some of this work. As you've heard from the previous presentations, the trusts who are involved in the research side will mostly be focusing on that recruitment and consenting of patients, whereas the GMSA have more of a role from a regional perspective, but also focusing on that condition suspected pathway, where it's really key to understand that patient journey and ensure that there's an efficient and effective referral pathway. We'll also be linking in with some of those key senior leadership professionals, so from regional networks, laboratories, trusts, and also primary care. We also want to be promoting awareness of the study and make sure that the messaging is clear about who and where this study is going to be. And finally, we also want to look at supporting the access of education and training around this project, but not just specifically on the study. It's about learning about the fundamentals of genomics and what it means for different services. I just want to go through some of these in a little bit more detail, but also to highlight that this is very early on in the project. So there's still a whole lot that we need to do. As Miikai had mentioned before, there are currently 21 trusts that have been identified and approached, and we do have one live within the East of England. But within the East GMSA, we cover both East Midlands and the East of England, and we've actually had a real lot of interest in trusts joining the study within the East. But again, it's just trying to make sure that we do cover those trusts that represent that diverse population and deprivation of the population, because it's so important. But also we do need to aim to get that 100,000 newborns. So it's a slow and soft approach at the moment to make sure that all the recruitment sites are progressing, and there's no barriers or issues to start with before we have that major roll up to sort of 30 to 40 trusts. And our role within the GMSA has been to support and coordinate and link in with those research midwives, support with that education and signposting, and actually collaborate to make sure that we all work as a team and we're listening to each other. So in terms of raising awareness, we've known about this project for some time now, and we've developed a local working group with some key stakeholders to really sort of understand what we need within the East GMSA. Along with that, we've done some bite-sized sessions with our local population, as well as engaged our PPV panel. So again, we're really pleased to have Rebecca and Vela from that PPV panel joining our working group to really give their views and support on this project. We've then also really focused now, as we're getting closer to those go live dates for the recruitment sites, to focus on the paediatric work, so linking in with the mapping of MDT meetings, and then also identifying links within the region and also outside of the region, including the screening networks and laboratories. Another part was developing those treatment and support pathways. To start with, we've had to look at that staffing model. So in the last quarter, we've been really busy with this, and it mostly aligns to the recommendations from Genomics England and NHS England, with the recruitment of our regional results coordinator to support that condition suspected pathway, and an operational manager that's currently within the shortlisting stage. But within the East, we also had to consider the fact that we don't have a dedicated children's hospital, and therefore a number of our paediatric patients will be referred out of the region to some of the highly specialised services. So we really wanted to ensure that we could bridge that gap with having a lead paediatrician within the region who could support some of those complex conversations with clinicians about that follow-up and management, but also assist with overcoming any local issues or barriers to delivering the study and providing support to families. Then in terms of resources, part of the role which included that dissemination or utilising training resources to support specialist speaking with parents. As we heard yesterday with Camerata and Genetics Alliance, patients will need that clear information provided as soon as possible, but it also needs to link to relevant support organisations to aid the well-being of that family with an unexpected screening result. And I do highlight that word, unexpected. And although we're aware that many specialists are used to talking to families about a diagnosis, a lot of the time at the moment, these parents may have already been on that diagnostic journey, either months or even years before, so expecting and almost relieved that there is an answer to these, whereas we are flipping it round, and these parents are not expecting to get a condition suspected result. So we need to have that clear, effective management with a good wraparound service for those patients. We then move on to the mapping, and this has been where I give a big shout out to Lauren, who is our results coordinator, who has done a lot of work around this, and it has been challenging, as I say, because a lot of our services go outside of the region. But we've now got a really detailed contact list, and we're also thinking about those patients who may move out of area, or thinking about a second clinician in urgent circumstances. We have mapped most of the east of England, and we're now focusing on identifying clinicians in the East Midlands. So if you're on this call and you're from the East Midlands and you're within that paediatric service, we would be really grateful for you to get in touch with us so we can start those conversations. Overall, the response has been positive, although we are aware that there are going to be challenges around competing demands. Most of the clinicians recognise the significance of this work and how it may improve outcomes for these children. And then finally, that last part of the mapping includes liaising with those screening teams, so that parents are not contacted by multiple teams for a condition suspected, but it's also about making sure we keep those communication channels open with the relevant teams so that we can identify and mitigate any challenges or concerns. So once we have our staffing model in place, we want to expand our reach to further stakeholders. As I say, we're still in the early stages and we need to go further, thinking about our health visitors and our GP services. But we're still waiting for some of that national communication before we do a lot of that work. But we do endeavour to provide more lunch and learns and more education programs to support this. But we also want to get the messaging right. We don't want clinicians delaying treatments because they think the research will provide an answer. The fact is that this study has not been done before, so we don't know what these results are going to show us. So going back to that initial presentation, which highlights around that newborn screening, and a lot of people may be asking or thinking, is this study the same or different to the newborn blood spot programme? So if you don't take anything away, this is just that mini education session, and I thank my colleagues Donna and Karen for this slide, which I've lifted because it has such important details to show that difference between the two. So yes, they are both screening tests and not diagnosis. And in both cases, we will need to perform diagnostic testing to confirm if that baby does or does not have that condition. The Generation study is going to look at many more conditions to the newborn blood spot, over 200. And that first line of testing will be genetics, so looking at the DNA. But in the newborn blood spot screening, we are looking at biochemical markers within the blood. And they are present because the condition may or may not be of that genomic origin. And one of the concerns is that midwives and parents will see this as a better test because it's looking at genomics and it's looking at more conditions. It's revolutionary. But we must be clear that the newborn screening is well established, evidence-based, and has that proven clinical benefit. It's offered to all children and improves the outcomes and even saves lives. This project at the moment will only be offered in a number of trusts, and we won't be offering this test to every site in England. We do not know if WGS will work within a population screening because it's not been done before, and we really have to be mindful of this. So again, as I say, if you only take one thing from these presentations, the Generation study is not replacing the newborn blood spot screening, and parents participating in this study must still be offered and recommended that newborn blood spot for their baby in the time being. If you do want to find out more, if you want to learn about the study, then there's a QR code that goes directly to the Genomics England webpage, and that takes you through all the stages of the process of this research study. But also, if you want to find out how to take part, again, there is some information for parents. Thank you very much.
Thank you, Jo. Our next set of speakers are covering a trio of case studies, NICU, PICU, Next Generation Children's Project, Hearing Loss Clinic at CUH. So pleased to introduce Maz O'Reilly, Principal Genetic Counsellor at Nottingham University Hospitals, Dr. Austin, consultant neonatal intensive care at Cambridge University Hospitals, and Helen Doling, research coordinator, University of Cambridge, and Dr. Berwick, consultant in pediatric ENT, Cambridge University Hospitals. Welcome, colleagues. Looking forward to hearing about the case studies.
Thanks very much, Emmanuel. Thanks for asking me. So I'm going to talk to you today about a pilot study that has taken place in the East GMSA to embed rapid genetic testing for acutely unwell children in this region. And I just want to start off by sort of mentioning the diagnostic odyssey that I'm sure you've heard about today, and if you've been on the showcase yesterday as well, that comes up so frequently for patients and families with rare diseases, and that it still takes often over 4 years to come to a diagnosis for these patients with rare conditions. And the aim of this particular test is to really try and change this. So I think the challenges to make a diagnosis are really acute when it comes to an intensive care setting. And just to sort of reinforce that, it can be very difficult to examine children. They may be intubated. To look at their development and what they're able to do or not able to do is completely impossible, because they're there because they're unwell, and so are not behaving in their normal way. Often they're very, very premature, and so features of a condition are just not apparent, and it's such an early stage in the diagnosis that some of the key features may just not have evolved at all by that point. However, in this sort of situation, there can be really good benefits from making a diagnosis early, and we're thinking about, should management be changed? Can it be improved? We know that parents are asking questions. They're very scared. They want to know what's happening to their child, and this can clarify the situation. But it can also make us aware of other risks for a child, or for other members of the family as well. So we have a very clear reason for trying to perform a diagnosis early on for these acutely unwell children. So just to recap for any of you who've never come across this particular genetic test before, it's a whole genome sequencing test, and it's designed, it's offered in the situation where we have an acutely unwell neonatal child who has features suggestive of a genetic condition, and in the situation where a genetic diagnosis could help with immediate change in clinical management. In my slide stack, I left off a rather complicated slide, but what I wanted to say to you is that the actual performing of this test is extremely complex. So it involves contacting the exeter laboratory with clear symptoms of the child, getting permission back from the laboratory to proceed, liaising with parents, usually who we don't have their details on any database because they're not, we don't have their NHS details. So liaising with the ward staff and the parents to arrange for 3 tests to be taken, ensuring that they are all sent off to the laboratory, but then also providing detailed information about the child, what's happened to them, how they're currently presenting. And this is really important because of the nature of the test that's being done. A lot of genetic testing will be taking place looking at a panel of genes which have a known association to a feature or a condition. And just to recap, when we do whole genome testing, this is what we call an agnostic test. So literally the laboratory is taking 3 complete sequences of the entire genomic sequence of parents and the child, and then comparing them, and then is analysing any situation where there is a difference. So they're looking for patterns, either a new variation in the child which is not present in the parents, or perhaps two variations in the child in the same gene, and then spotting that both of their parents have one change. So then they go backwards from this to look at the gene and say, can there be an association with the way that this child is presenting? And that's why we need this very detailed information at this point to provide the laboratory. The whole test is designed to be performed rapidly, and generally we get the results within 3 weeks, but the future of this is to get it even more quickly. So the pilot that we set out was to try and improve the delivery of this test across the region, because we know how busy and how that the neonatal staff are, and how this kind of goes down in when they're actually dealing with the now and the current symptoms that a child is presenting with, how genetic testing can sometimes fall off the radar. So actually having people who can go to the ward and take responsibility for gathering of the samples can be really, really helpful. We also wanted to use this test. I'm going to come on to cases in a little bit, but I just wanted to talk about this a little bit to say that we wanted to use different allied health professionals to support the consultants to actually help to show the trust that this was also cost effective, as well as being really helpful for the parents and the intensive care clinicians. This was also an opportunity to provide education and awareness for paediatricians and staff in the region. So we set up with a pilot, and we wanted to encompass the entire region. So the centres were Nottingham and Cambridge to start with, and then Leicester. And the next slide just shows our sort of timescale for rolling this out. So we started our phase 1 pilot, and the East GMSA funded us for some genetic counsellor time, and also for Nottingham, and also for for registered nurses to do a similar role in Cambridge. And then we brought on Leicester as well, who have employed a third model. So we were comparing 3 different ways to support this testing using different allied health professionals. As well as this, we set up educational sessions for the region, as well as monthly virtual meetings to just steer the project and to share best practice between the three teams who were implementing this. This is a very complicated slide, and I'm not going to go through it in great detail, but just to say that obviously we had to set up very careful pathways, and again, sharing best practice helped us to iron out and get to better pathways more quickly by working together across the region. The educational sessions were held in different ways. So we used the East Genetics Paediatric Forum. We did sessions particularly for the NICU and PICU staff, as well as general talks to paediatricians. And we covered the practicalities of how to take samples, to discuss with them the urgency of these tests and how they could help. A lot of ethical dilemmas came up about the types of results that might come about from this, and how to manage those. We had to be really careful about what would be tested, what wouldn't be tested, and talking about incidental findings, so things that could come up out of this test. It's a very powerful test, which were completely unrelated to the child's presentation. So just to compare how this went, we looked at the national picture when this test was first rolled out, which was back in 2019, and looking at the laboratory data from Exeter, by the time they'd gotten to that 4 years down the line, they were finding a diagnosis for around 1 in 3 children, just over 1 in 3 children tested. As part of the analysis of this project, we did some deep dive data analysis, and for the Nottingham data, I think a couple of things I want to point out here is that putting people in place to do this really helped. So if you look at the increase in testing that happened from 2021 onwards, you can see that it peaked. We're now routinely doing around 80 tests a year in the Nottingham area, and the 2024 data just goes to April. But again, we're online to carry out a similar number of tests this year as well. and around just under 30% of our families have had a clear diagnosis as a result of performing this test for them. Just to let you know that as well as piloting this, we carried out an evaluation. I'm not going to talk about that in too much detail because I want to focus on some of our families in a minute, but just to let you know that we did do a cost benefit analysis, as well as looking at how we could then build on the actual service that we were offering. And one of the things that we have initiated in the Nottingham area is a virtual board round to try and help the clinicians to spot children and infants who may benefit from one of these tests as well. So one of the things that we looked at in our analysis was how many patients, what percentage of patients actually benefited immediately from a change in management. We took a sample of families where we for 2 years between 21 and 23. And in this particular cohort, around 27% of the families received a diagnosis, but you'll see actually a slightly higher number of the patients had a change in management. And that's because sometimes a normal result can also help inform management decisions. I want to just focus on 3 of our families now. For our first child, they had presented with seizures in infancy. And had several repeat admissions to hospital because of the seizures. On the 4th admission, when they were 5 months old, an R14 test was performed, and this delivered a diagnosis of a mitochondrial condition. The child had 2 NARS2 genes, and this is a known related neurodegenerative condition. So how did this impact on the patient's care? Well, the first thing was that some medication was actually stopped because it was contraindicated, because there was a risk of liver failure to this child because of the now known diagnosis. Looking back, some of those earlier admissions could have been avoided if the condition had been identified earlier as well. The child was able to be referred to the Newcastle highly specialised mitochondrial service. Sadly, this is a life-limiting condition, but we also know this is a recessive condition as well, which means that we could talk to the family about the risk for further children. There was 25% risk that a further child could be affected with this, and that there are some reproductive options available to them, such as prenatal testing, assisted conception, and to give them some possibilities for future. This was a really difficult situation for the family, and we were able to provide some continuous support as well as signposting the family to support groups. In this family, the baby presented with hypotonia and stridor, and all the standard investigations were normal. And then an R14 was suggested, and the baby was found to have a variant in their TNNC2 gene. Now, this is actually associated with a rather unusual myopathy, so a muscle weakness condition. This was really helpful though, because the neonatal team were then able to avoid a number of procedures for this child, including muscle biopsy. The management that was indicated was supportive physiotherapy and with respiratory and neurological follow-up. And this is quite an unusual condition because the symptoms tend to improve with time in childhood. And for this particular family, it really helped the mother to bond with the child, knowing that was their prognosis in future. And the third family I'd like to talk about is about a 10-year-old boy who was admitted to intensive care. And there had, for reasons unknown, there had been a delayed response, possibly through the COVID situation, and investigations had been delayed following this child's regression. However, they had an MRI scan which suggested that they had a rare leukodystrophy, which is a very significant condition. And so R14 testing was performed and quickly confirmed that they did have this condition. They had 2 ARSA gene variants. And this was very significant in terms of the family and the outcome for the family, because first of all they were referred to the specialised team at Manchester, and unfortunately this is a condition which can be cured with gene therapy, but in this situation the child's condition was too advanced. However, as I've said, this child had 2 variants in their genes, and this is an autosomal recessive condition, and we identified after that both of the parents were carriers. Now, having taken a family history with this family, we knew that they had a younger child as well, and we performed rapid testing which showed that very unfortunately that child also had 2 gene variants, and so would have gone on to develop metachromatic leukodystrophy as well. Obviously an incredibly difficult situation for the family. However, this child was young enough to be referred to Manchester to have gene therapy. So very difficult, but one outcome that came out of this was positive for that family in terms of being able to access quickly diagnose the younger child prior to development of symptoms. So I think I'd like to just sort of go through the benefits again of this pilot, to say that the R14 test clearly avoids unnecessary and invasive testing for children, and it can allow redirection of care, quite often changes in medication or management, or sometimes to palliative care instead. Some of the work of this pilot has helped us to raise the profile of this service, and so that we know that referral rate has improved in the Nottingham and also in the Leicester and Cambridge areas who've done very similar parallel work to us, and has improved the links between the intensive care services and the genetic services as well. There are also many benefits to supporting families at this time and giving them clear information. We're able to signpost them to some of the wonderful support groups around, such as Unique, and to help when they have when they're thinking about having future children, and also, as I've said before, to identify if they have any other children at risk as well. We did carry out a cost benefit. It's not something I particularly was going to dwell on in this particular forum, but I think it is helpful to know that, if I can have the next slide, we did an in-depth analysis of 6 patients using the Nottingham costings team, and just through 6 patients we were able to just evidence a significant cost benefit, which we think more than offsets the additional support to raise the profile of the availability of this test to the acute care services. So I'd just like to acknowledge the very large number of people who've been involved right across the region in supporting this test, and to our GMSA partners who have done a lot of work in helping us to evaluate this as well. Thank you.
So, good morning. So I'm Jessica Buick. I'm a paediatric ENT consultant at Addenbrooke's in Cambridge. Thanks for inviting us to talk to you about our new clinic that we've set up for the last couple of years. I'm here on behalf of the whole of the MDT who run the clinic, so it's a pleasure to be able to tell you about this. So just a bit of background. So Addenbrooke's hosts sort of the East of England implant centre, and we also take some complex implant, so cochlear implants, etc., from around the rest of UK as well. So we have a large cohort of both paediatric and adult patients with hearing loss, and often quite complex patterns of hearing loss. And then on top of that, we also have a considerable number of children who come to our audiology centre at Addenbrooke's purely for advice and workup around their hearing loss. We have a very keen and active audiology service, many of whom have some research interests as well. And because of that, we run a fairly successful paediatric hearing loss MDT, which happens every month, and that's been the case for the last sort of 8 or so years. Within that hearing loss MDT, we take on children with both, all the way from the sensorineural hearing losses that are diagnosed on the newborn hearing screening programme, all the way up to those diagnosed just before they go into adulthood. And they're all discussed on a monthly basis. So the combination of those three sort of areas, we have a significant proportion of our patients who are often a diagnostic conundrum when it comes to investigating reasons for their hearing loss. And then on top of that, we have a very active research interest within the ENT department at Addenbrooke's. You may well have heard of Professor Manohar Banth, who I'll come on to in a little while, who's been in the press recently because of some of the work he's done linked to this area. Just as a background in terms of investigation for hearing loss, it's a bit like searching for a needle in a haystack. So for children who present with sensorineural hearing loss, and that is hearing loss that is based either within the cochlea itself or within the auditory nerve, they're very rare causes, and there is no real one specific test prior to introduction of the R67 hearing loss panel that we were able to run. There is great guidance from the British Association of Audiovestibular Medicine in terms of what investigations should be introduced at any particular age. If you had a new baby who was presenting with hearing loss, you would be expected often to perform up to 10 to 20 different investigations, which would require multiple trips for that family to hospital. And some of them were, fairly invasive. If you're an adult and you have sensorineural hearing loss, it's either put down to presbyacusis or you've been pretty unlucky in life. And there have been virtually no diagnostics really advised for adults, despite some really interesting patterns of hearing loss in the past. And pre to 2021, which is when we started using the R67 panel fairly regularly, we're only really able to test for GJB2, the most common cause of sensorineural hearing loss in the UK. And we were really behind the curve on that. If you look at our colleagues in Holland, they've had a very active genetic diagnostic system for quite a while. So along came the R67 panel, and we quickly had to put that into our practice in ENT. And that was because all of the genetic referrals that we were previously sent from our children's hearing loss MDT were bounced back by our colleagues in genetics, telling us that we had to take on the counselling and ordering of the R67 panel. Luckily, they had a fairly proactive ENT department who was happy to take that on. And we started to integrate the R67 panel from 2022 onward, really. Just to run over, so the R67 panel was designed primarily for children and adults who have sensorineural hearing loss, which is bilateral. You can put forward cases for unilateral loss if there are other additional features suggesting syndromic loss, or if there's a good family history, which you've demonstrated with audiograms of bilateral or unilateral hearing loss, and there's a general feeling that there may be a monogenic cause within the family. The panel, so it started off at about 110 different genes. It's now, I think, up to about just close to 150. So it's becoming more and more comprehensive. We're still not quite at the stage, I think, of our Dutch colleagues are, but I don't think we're far off now. And within there, you've got all from your very common GJB2s to other syndromic causes, which are considered, pretty rare to see in even a high volume ENT practice. So in terms of what we're doing now, so I started training into doing counselling for consenting for the test 2022 onwards, much supported by Gemma and her team, with some of the online educational resources, which were excellent, I have to say. We now have a specialist nurse and Professor Bantz, who will also order in a couple of the other implant surgeons. And pretty much all of the patients who go through our cochlear implant service will have an R67 alongside those children who are coming through our hearing loss MDT. When we started getting results, we realised there's a real opportunity to be able to learn from the results. And what we didn't want to do is be generating a lot of data and not understanding some of the disease pathologies that we were seeing. So instead of referring all of the positive results into the genetic service, we decided we wanted to embrace it more and set up a joint clinic to improve our understanding and also improve the patient experience. What also coincided with this was the opportunity to join a trial in gene therapy, and that is why you will have probably seen Professor Bantz's name up in several media outlets over the last 6 months, has been involved in one of the very first gene therapy trials into hearing loss, where we have a patient with a very successful outcome. There's a little lag on the slide changing, which is why I grind to a halt. So in 2021, April 2021, when we started, we set up an MDT followed by a clinic, and these are the personnel who are involved. So we have 3 from ENT, so Prof Bantz, myself, and Matt Smith, who's an academic otologist. Within genetics, we have Dr. Simon Holden, Dr. Ramsey Bowden, who have taught us a huge amount over the last 3 years. We could not do this clinic without Sarah Collis, who's our PA, and has been incredible at organising us all. We have nursing support from Deepa John, and we've had many observers. We have a lot of international visitors to the department, and they're all very interested to know how we run this clinic. That's interesting. Okay, now. So in terms of the clinic, so the criteria to get into the clinic is that you need to have a positive diagnosis. We don't see those with negative outcomes, and we don't see those for consenting. We have an hour-long MDT, so all of the positive results that have been generated in the last month will be discussed in the MDT, which often takes longer than an hour, but is very interesting. And there we'll try and sort of suggest as many phenotyping testing as possible that needs to be generated from that. We then have a 3 to 4 hour clinic, which is run monthly, and that's a combination of face-to-face video and telephone appointments. We started off at 45-minute appointments, but actually we've been able to come down now to 30 minutes. And that's primarily because we send some information out to the patient before, so they already actually know usually their diagnosis beforehand, unless there's something particularly sensitive about it, then we'll only do that in clinic. In terms of who's invited, so obviously the patient, and if they're a child, obviously a parent, preferably both parents, and then we will invite other family members if there is a hearing loss history. The clinic is run out of our ENT department, and that gives us a facility to be able to perform audiograms for those family members, and then other investigations such as OAEs or vestibular testing if needs be. Prior to clinic, we've done pretty well at getting family trees established so that we can go through and add information to those within the clinic appointment. So last year, we performed a service review, and these are results for our paediatric patients only. There are a significant number of adult patients as well, but this is just the data for children. So in the first 2 years of running the clinic, we had 52 children who had who underwent the R67 panel. The mean age at the time of testing was just under 7 years old, but there's a big range. So you have all of those from your newborns all the way up to those just entering adult services. The hearing loss, in terms of the range that we were seeing, it was everything from mild sensory neural to profound, and all of the cases were bilateral. Several patients had a positive family history. And then if you look at the breakdown, so in the green, we can see those with positive diagnoses, so 65%, and we've got variants of unknown significance at just below 8%. And the rest of those children who had a negative result. In terms of those 34 patients where we have seen a positive result, the 25% were found to have a syndromic cause, which is about in line with what we would expect from the literature when you investigate hearing loss worldwide. And then non-syndromic, 75%. Now, the vast majority, as one would expect, are autosomal recessive conditions such as GJB2, but we've seen a very large spread. And actually, when we update, we're just in the process of updating our service review at the moment, and we have seen a huge variety of diagnoses, which has been absolutely fascinating, and really expanded sort of the knowledge within the department about the population that we are treating. And we've been talking a lot about the future of the clinic. It's something that we very much want to keep going. It's been run a lot on goodwill at the moment, in terms of people's time and effort. What we all, I think, would want to put forward to all of you is that you can't underestimate the new understanding that comes from doing this. I think working with our colleagues in genetics has massively improved our practice in ENT, and that's important not only for our patients, who often would never have had a diagnosis prior to introducing the R67, but also on a research forefront. So I think we can predict that there will be a gene therapy rush, just like a gold rush in genetic causes of hearing loss. I mentioned that Prof Bance had performed one of the very first gene therapy for the OTOF gene worldwide, which is incredibly exciting. There are many companies out there at the moment developing new gene therapies for hearing loss. And the benefit to patients can't be underestimated, but it's going to be hugely profitable. So I think there will be so much work on this in the future. And we hope that we will have a cohort of patients within our clinic that we can go to continue to be involved in some of that research in the future. We're looking at streamlining the clinic. So there are some of the diagnoses we don't feel that we will need to continue to see. So for example, GJB2, we have developed some literature to send out to families, and then we will offer counselling if they want to take up on that. One of the areas that we're not testing is mitochondrial disease, and while it's exceptionally rare, we're testing for a lot of other rare conditions, and I think we need to look at how we might work that into our clinic and testing in the future for those with negative R67s. And then we are trying very hard to do some work entering phenotyping into Decipher to aid understanding from the results that we're generating for our population of patients. I believe there is some research money coming on that which will help us, because obviously it's a huge amount of work to keep up with that database. So that's all of my slides. I'm happy to take any questions, or I can stick around till we've got to the end of this session.
Brilliant. Thank you, Dr. Buick. If you could stick around, that would be helpful. We'll take questions at the end of the session.
Right. Thank you. Yeah, so Helen and I are going to do a sort of double act, and just because of scheduling, we're slightly going back in time, because we've heard all about R14 and then sort of the exciting work with ENT. But with the Next Generation Children's Project, next slide, please. we're going back to around sort of 2016, when a project was developed with Professor David Ravitch and Professor Lucy Raymond to do rapid whole genome sequencing in the NICU and the PICU. And the question being asked was, can we detect genetic disease in the neonatal and paediatric intensive care unit using this technology? Well, we know the answer now, yes, but just I'm going to sort of take you through the sort of journey which led to that. And we were looking at, I'm a neonatologist, and my sort of bread and butter work is looking after preterm infants or infants with sort of various surgical problems or acquired brain injury. But there are a significant number of children who have atypical clinical features, and the question is what is the role of whole genome sequencing in that? And can you get a rapid turnaround which would give clinically useful information both to clinicians and to parents? So looking at the pathway, it's quite a sort of convoluted pathway going both from research into the clinical practice. So the first port of call, and with Helen, we meet once a week and go through all the patients on the neonatal unit and discuss their problems, and the ones who just didn't quite fit a sort of standard, say, 28-week preterm infant. There were some features which just seemed atypical. And then the hard work, which Helen will sort of talk more about family recruitment, getting getting trio samples to the labs, and then generating the data through Illumina, and then having got the data, having an MDT meeting to sort of decide, is this actually something which is clinically significant? And because that stage up to this point was under a research project, it then had, in order to sort of feed back into the NHS, had to be sort of validated through the standard NHS laboratories. But we were able to sort of get it down to around 2 weeks in the end. And so this probably follows the sort of standard R14 pathway now, but in this project, it was kind of trying to develop, how would this pathway work in a clinical environment, dealing with both the hospital, the labs, and because it was research, the university. And the challenge as well, once you've sort of identified various candidate variants, is to say, is this actually of significance? So both either pathogenic or likely pathogenic, with only a few variants of unknown significance were reported. Otherwise, you got a negative report. And as I said, all positive results have to be independently confirmed, given the sort of significance of what a positive finding would mean using what at that time was a new test. So for the next few slides, I'm just going to sort of go through sort of two parts of the project. Recruitment continued right through to, I'm going to say 2020. 2020. So over 4 years, but we published in work of the first sort of tranche of patients from both the NICU and the PICU. So this is data from a total of just under 200 infants and children who were analysed, although nearly twice as many were identified. And I think there's about 33 different cases here, and it just shows the sort of wide spectrum of cases that we were able to detect. And not necessarily relating to sort of the initial phenotype. There was something possibly atypical to the sort of standard neonatal condition from a neonatal perspective, but it wouldn't necessarily predict what the actual outcome was. And this is looking at all these 33 infants who had, and children who had a diagnosis, and asking the question, did it actually impact on care? And this may be referral for more specialist treatment, modification of treatment, or providing a recurrence risk to the family, or in the case of sort of lethal conditions, whether it's sort of helped in the sort of acute management in terms of redirection of care. And you can see a significant number, nearly almost half of them ended up having new specialist care initiated, but pretty much every infant it impacted on their management pathway in a sort of significant manner. And then for the second part of the project, we extended the rapid sequencing to patients in the paediatric neurology clinics and also in clinical genetics. And so the total next generation cohort consisted of 521 patients, around 37% from NICU, 23% from PICU, 23% from paediatric neurology, and just 17% from clinical genetics. We had, I think by the time patients are sort of in the paediatric neurology or the clinical genetics clinic and still don't have a diagnosis, it's perhaps not surprising that the recruitment rates were high, 80 to 88%, but our recruitment rate amongst NICU and PICU patients also increased. So it went from just under 50% when the project started to nearing sort of 75-80% towards the end, and that is possibly because of us identifying patients where the diagnosis was less clear. Just looking at this slide, this is just showing the sort of average age of recruitment. As a neonatologist, I'm just going to focus on the red one. We were recruiting most of them within a sort of week to 10 days, so relatively early on in their journey. I'm not a geneticist, and this slide kind of slightly blows my mind, but it shows the bioinformatics pipeline, and I think it shows the sort of real sort of potential of doing whole genome sequencing in a sort of agnostic manner, that you can look across everything from gene copy numbers to sort of the overall chromosomes, and depending on where you go, you can interrogate lots of different conditions. And just focusing on the neurological side of things. So this is looking at the diagnostic rate in infants who had presented with either seizures, developmental delay, or hypotonia. It's a bit of a busy slide. I should have sort of highlighted some numbers. But if we look at the patients with hypotonia in the neonatal unit, almost half of the patients who were identified ended up with a genetic diagnosis, which is quite significant given that hypotonia we tended not to sort of over-investigate them during the neonatal period. They'd often sort of go off to paediatric neurology clinics and be followed up there. Perhaps not surprising, the diagnostic hit rate was around sort of 45 to 50% within the paediatric neurology and genetics clinics, but we still had a relatively high rate in all clinical features in the NICU and the PICU. The overall average rate was nearly 35%. So just summarising what this sort of project demonstrated, that the gene agnostic approach, it has advantages that all genes are considered equally initially, regardless of what the phenotype is, and the HPA terms are not used to select genes to be considered in the initial analysis, which doesn't enable new and previously unrecognised phenotypes to be assigned to known genes at a significant rate, which would not otherwise be known on a panel. Then there's a huge sort of learning curve in terms of training, communicating genomics between the clinicians and the families, and we hugely benefited from Helen's experience. And then as the R14 sort of took off, we had specialist nurses on the neonatal unit, and then this leads on to what does it mean actually for the families in undertaking the test and in having a genetic diagnosis. As a clinician, we love to get a diagnosis. We want to do it quickly, without necessarily thinking what the implications may be for the family in the longer term, and that's something Helen's going to sort of talk about shortly. And so I mean, we now do whole genome sequence. It started with whole exome sequencing, but I think this study was one of the sort of drivers to sort of expand it nationally into the R14 panel. So I'll now hand over to Helen.
So thank you for this opportunity to talk about the new data from my PhD, which is now nearly completed, or the analysis is complete anyway. So I will be presenting the follow-up study with the Next Generation Children Project parents, which is the Peregrine study. And this study was set up through the bioresource, going back to the families, interviewing mothers and fathers individually and asking them to complete a range of questionnaires. Here are the demographics. So 96 parents took part in this study, which was mixed methods, as I mentioned, and 91 of them completed full-length interviews, which were on average 1.5 hours long and sometimes lasting 3 hours over a couple of sessions, which was very much indicative of the fact that parents had not had opportunities to really debrief about their experiences of being parents in intensive care. They came from both NICU and PICU, but also from neurology and genetics clinics, and talk about their experiences in a manner that helps them to put a story together for them as an individual and for a family as well. So the parents who took part were 58 mothers and 38 fathers, and I asked them about a range of questions related to benefits and harms of whole genome sequencing from their perspective, whether they experienced decisional regret, and what their support was like subsequently after the genome sequencing and in the current life. There is a whole range of different backgrounds here, but this is pretty much what we see in Cambridge. When I presented this slide elsewhere in the country, they were a little bit surprised by the level of education, but this is very much in line with what we see in Cambridge. So there are many ways of looking at the benefits and harms of whole genome sequencing, and the literature across different cohorts, including adults who are pre-symptomatic with familial conditions, including those who have symptomatic already have an onset of symptoms, and through the pediatric cohorts, the data for which has been emerging in the last 10 years or so, have detected several different kinds of benefits, and these can be quantified in 5 different ways: social, behavioral, medical, affective, or which is emotional, and cognitive. And this was very much true for this cohort as well. So I used the framework developed by Kohler and Haems on the basis of extensive literature review and prior studies to look at whether parents in this cohort of rapid genome sequencing had similar experiences in terms of personal utility. So there is a lot of talk about clinical utility, and early literature in genomics has been based on the clinical validation and then utility and feasibility. And Topun mentioned that our study was set up initially to look at that feasibility and acceptability as well. And subsequently, what the parents are saying that for those who got a genetic diagnosis, but sometimes for others with clinical diagnosis, the genome results, be it negative or positive, informed further investigations or reduced the investigations they needed. For some, it meant access to treatment and specialist clinics and confirmation of clinical diagnosis. But there are other benefits which are related to coping and well-being. So parents expressed enhanced coping, but sometimes that could also be reduced. And they felt a reduction in terms of personal responsibility if a condition was de novo, for example. It also helped them to mentally prepare for the future and to adjust and adapt to their family circumstances. And of course, having knowledge about the condition can be helpful in terms of making plans for the future, making sense of the child's condition, and sharing that information with medical, social, and educational community. So the parents in the study who signed up, because this is a research study, of course, who consented to the study, on the whole, believe that knowledge is power. However, sometimes ignorance can be bliss. And even in that cohort who had agreed after intensive discussions around consent and benefits and so on about whole genome sequencing, they varied in terms of how much knowledge they wanted. There were still some parents who said that they don't want to know if their child has a life-limiting condition, and restricted their access and sort of engagement with certain types of information online, so as not to find out information that they weren't ready to see or hear yet. But on a whole, this mother here expresses the benefits of having that extra information that can reduce uncertainty and clarify the future pathway. However, waiting for a diagnosis can be very difficult, and it's important to understand what parents' expectations are. Some parents understand that whatever comes back from that diagnosis may be life-changing for the child and for them as an individual and as families, especially when a condition can be life-threatening or life-limiting. It's important to understand what those expectations are. Sometimes they might be misplaced and other times unrealistic, but that can give us a window into understanding what that waiting time might be like on an individual basis. So, as I said, knowledge can be power, but it can also be shocking. And for several parents, they expressed the shock that they experienced when they received that diagnosis. And yet they felt that this knowledge is important in planning their child's life and making sure that they get the best benefits from the support that can be put in place for them. In terms of therapies, in terms of equipment and other factors. Parents sometimes experience the diagnosis differently, and there were different aspects that they mentioned. Sometimes the setting wasn't conducive to receiving that difficult information, and that can make a big difference to families. A few fathers talked about getting a diagnosis and feeling physically affected for several weeks, not being able to sleep or eat or think about anything, and their work was being affected, and not knowing what to do with these feelings and those physical symptoms. So it's important to think about what potential impact beyond that individual and thinking about the family as a structure and how the individuals within that can respond very differently. Some parents talked about experiencing guilt. A majority, or nearly 60% of our diagnoses were de novo, and that tends to be the case for neonates in the literature as well. But there were some families who received autosomal dominant diagnosis or recessive conditions or mitochondrial diagnosis, and it's important to think about impact on the parent. However, it's also important to recognize that some mothers who had children with congenital anomalies and did not receive a genetic diagnosis carried that guilt forward with them as well, thinking that there might have been something they did in pregnancy that caused those symptoms. So guilt can be both generated by the knowledge of genetic inheritance mechanism, but also by not receiving a diagnosis. And it's important for clinicians to validate parents in the normality of those experiences and feelings. Parents' responses can change over time. Some people cope very well initially because maybe they were very keen to reduce their uncertainty and get some answers and to move forward with a life in the light of knowing the diagnosis. While for others, perhaps the shock is great, as I said earlier, at the outset, but they adjust relatively well and move on a different trajectory for those who over time become more affected and needing psychological input from specialists. So those parents who receive a diagnosis of life-limiting or life-threatening condition require support throughout, and the knowledge that they will not be left to deal with this on their own. So when I looked at decisional regret, all of the 91 parents said that they would make the same choice again if they had to do it over again. And the majority of them, so 90 out of 91, said it was a right decision and they don't regret the decision. A few parents said that they didn't like the word wise because they didn't consider themselves wise, but on a whole they felt it was a good decision and the right decision. However, you can see that there are some parents who experienced harm. And there are several reasons why they said it was harmful. Some parents had received VOSs, or variants of uncertain significance, in pregnancy through the NHS. Sometimes these are familial condition, and it wasn't clear if they were relevant to the child's presentation. On other occasions, parents had received other non-diagnostic results and were felt that their anxiety and depression had increased, which lasted into the early half of their child's life, and subsequently 3 years later, when they were being interviewed, they expressed concern that this may have affected their early child parent relationship and development for the child. So it's important to bear that in mind. Some parents felt that they weren't actually quite sure what the results might mean, and subsequently realized that if they'd received a life-threatening or life-limiting diagnosis, they might not have been able to cope with it, or their marriage might not have lasted. But on the other hand, those who did receive those diagnoses, I also included parents whose children had died in this study, felt grateful. It had given them closure, it had given them reproductive autonomy, and had been very useful in planning their lives around that knowledge. But for parents who received diagnosis of mitochondrial conditions or some epilepsy syndromes with life-threatening elements to them, talked about increased hypervigilance and monitoring at nighttime, monitoring infections and so on. And those parents who received a diagnosis of a lifelong chronic disability were worried about their child's future when they no longer can care for themselves or have passed away, and what would happen to them. And then, of course, I talked about the ongoing feelings of guilt, which was present in both those who did and did not receive a genetic diagnosis. And the last one was new uncertainties. With rare and ultra-rare conditions, there is limited knowledge available about long-term outcomes for many of these conditions that we can now diagnose in infancy. And so that can also be an issue for some, and need some support. When I looked at the level of support, the majority, which is nice to report, of parents, both mothers and fathers, reported that they felt well supported or they had sufficient or high level of support. However, you can also see that there is a percentage of parents. So overall, if putting the mothers and fathers together, about 26% of them reported no or minimal support. And this was specifically in the group of parents who had received a diagnosis rather than those who had not. And there are some differences in terms of long-term outcomes for them, which I don't have time to go into in detail. But that is an important thing to bear in mind, that there is a subpopulation of families who feel that they are not receiving the support that they feel they could help them. And here is a piece of advice from a parent with an ultra-rare diagnosis in a daughter. He said that it is really important that even if you don't have that full knowledge of what the future holds for a family, that the family should never feel that they will be facing this path alone and that there is no further support available to them. So it's important to acknowledge parents' uncertainty, ongoing uncertainties and concerns over future, and to make sure that they know where to turn for support when needs be. Almost everybody said that they felt that despite the psychological impact, increased anxiety and depression in some, and lack of support, it was definitely worth going forward with the whole genome sequencing. And one parent whose child had, who was older, felt neutral about it. And there were, as I said, there were multiple different reasons why they felt it was worthwhile, which can be classified as clinical, social, behavioral effect, emotional and cognitive. So in conclusion, this cohort had low decisional regret in terms of going forward with genome sequencing, regardless of types of results and different diagnoses that they received. However, adjustment can be very variable in families and within the couple as well. And it can be an emotionally complex journey and sometimes lonely. Support needs change over time, and we need to be mindful of what we can do to help families navigating this pathway. And here are some suggestions in terms of how, which is allowing questions to be asked later when the adjustment has occurred and they are willing and ready to talk about longer term, acknowledging the feelings of grief, guilt and isolation that can occur, and signposting them to appropriate support and resources, as well as empowering parents to giving them sharing coping strategies and practical support and working collaboratively. Thank you.
Our next presenter is our education and training lead, Dr. Gemma Chandratillake. Hi, Gemma.
Hi. Thank you so much. Okay, so I'm the education and training lead for East Genomics, and so I'm sort of tasked with trying to support healthcare professionals to incorporate the genomic medicine service into their patient care pathways. And I think it's helpful to sometimes take a step back and think about the enormity of that challenge. So if we think about the NHS, we are the biggest employer in Europe, the 5th largest employer in the world. Yet we only have a couple of hundred clinical geneticists and a couple of hundred genetic counsellors in the system. So most healthcare professionals haven't really had a training in genetics and genomics. But we know that due to the small population of genetic specialists, we know that these genomic services will have to be delivered by non-specialists. And so we term that process mainstreaming. So what do we mean by mainstreaming? We are not trying to make all healthcare professionals to become genomic experts, but they do need to know when testing may be relevant for their patients, and they need to know how to request it, how to have conversations with patients, families and carers about the results. However, we had done some scoping work sort of in 2016, both at regional level and at national level, and then we repeated some scoping work in 2021 across our region. So we did big workforce surveys, which demonstrated that there was a lack of awareness of genomics in the mainstream healthcare workforce. There had been a lack of training in genetics and genomics. There were some training opportunities available, but there was complete lack of awareness of those opportunities. And there was a perception that genetics and genomics were irrelevant to those healthcare professionals' roles. So we had a lot of work to do. And these are just some quotes from some of those surveys that we performed back in 2016. So people saying, I haven't heard this term before. I don't know what it is. I don't know what it involves. It's the first time I've heard of it. I don't think this will impact on my role. I'm not aware of this field. So that's our starting point. So at that point, there was a lot of effort that went into producing some resources at national level. And there is a national genomics education program. And that team really work across the board to think about workforce planning, workforce development. They work on making educational opportunities available to NHS staff. So they provide funding for people to upskill in genomics. They also create resources. So they have e-learning courses, etc. They have a lot of resources for trainers to use. So rather than us all drawing pictures ourselves and making slide decks from scratch, we are able to kind of use the resources that they've made centrally available to us. They've worked a lot with different stakeholders. So for example, with the Royal Colleges to try and implement genomics into training curricula as well. And they do a lot of work on raising awareness as well. So this is just the types of activities that central team have really been involved in. So at the top of the pyramid, we can see there's actually some formal training programs that they've established. So they are funding trainees, scientists, to increase the capacity of the work of the laboratory workforce and the genetic counselling workforce. They are also, as I said, they have commissioned master's programs around the country. So in terms of formal education, there are several universities around the country that have master's programs that are funded by this program for NHS staff. So we promote and these programs within our region and try and let people know about them and the opportunities there. I'll talk more about that in a second. They provide online courses and sessions, and lots of videos and films and fact sheets that are useful, and they're also very active on social media as well. So if you haven't been to the Genomics Education Programme website, please go and have a look at some of the resources that are available there for you. In terms of the master's programmes, these are run at several universities around the country. In our region in the east, the University of Cambridge has been commissioned to run this programme. There are other universities available, but a lot of us from East Genomics actually work on this programme and teach on this programme. These are the modules that I would really recommend anybody who's working in prenatal or paediatrics to take: an introductory module, common and rare disease module, and a counselling skills module. Those are really, really helpful modules for any of you working in that space. And if you get super interested, you can take some other modules too. Another centrally developed resource is GNotes. So GNotes is a just-in-time educational resource for healthcare professionals designed to be used in a clinical setting. So please Google GNotes and you will find that there is a vast array of support. It's very, very tailored to clinicians. It's been developed by clinicians for clinicians. So it's basically walking you through clinical case scenarios in your area of work. So there is one for fetal and women's health, and there's also one developed for paediatrics, as well as these other areas of care. Again, on the Genomics Education Programme website, you can find there are some relevant resources. So there's resources for midwives, resources for nurses, resources for health visitors, and resources for those working in paediatric setting. So do check out the Genomics Education Programme website. As I say, the team have been working really closely with NHS England and various colleagues across the country to try and embed genomics into various different training curricula. And if you so we're thinking about the nursing workforce specifically, there is now being developed a competency framework in genomics for nurses. So these are just the high level points of that framework. And you can look that framework up as well. So this is really explaining what all nurses should really know about genomics and how to be competent. However, we know from our from the work that we had done back in sort of 2016 and 2021 that it's quite an issue to try and develop this in the workforce, because the people who are training the workforce of nurses don't necessarily have these competencies themselves. So it's quite challenging for them to train the nurses of the future and the nurses who are currently in post in these competencies. So we've also been looking at developing resources to support trainers. So to that end, here is a nurse educators toolkit. So if you are someone who's involved in training nurses, you can use this toolkit to support your training, to enable your trainees to develop those competencies that have been established. That's all sort of work that's been going on at national level, and we've also been working across our region to think about where we can influence the training system. So we've been working with the deaneries in the east of England and in the East Midlands to look at medical training. So this is the pathway of training for a doctor. You start off at medical school. We don't have a lot of influence on medical school training, but we work with the deaneries so we can catch people at foundation level and then at the specialty training. And then the other piece of work that we really have to do is think about all those doctors who are fully trained who will not have received this training going through the system. So we're working at foundation and specialist training, and we've also been establishing communities of practice. So at foundation level, this is a post-medical school pre-specialist training intervention point. So it's quite attractive for us because it means that we can do this across the region and we can hit all types of future doctors, including primary care clinicians. So we can just kind of do a genomics intervention at that point. So we've been running this intervention since 2018. We're still running it. We run half-day events every year, several of them across the region. And what we have noticed is over time, the trainees are coming with more genomics knowledge, but they're not. That's not consistent. So it just depends on where they receive their undergraduate training. We do have a lot of international colleagues as well joining us, so we don't have control on the training that people received before this point, but this is a uniform intervention that we're able to apply across the region, and the reception of this information has generally been very positive. One of the other things that we've been doing is working with our deaneries to try and understand whether or not any of the training programs that they're delivering have actually incorporated genomics into their training. So in 2021, we did a survey of our training program directors, and just with respect to this pie chart, the thing to focus on is the very small pale blue stripe, which is those who have answered yes to the question of whether you think you're doing a good job of training in genomics for your specialism. So we can see from this that generally genomics hasn't been well incorporated into training curriculum for medicine in our region. Thinking about paediatrics and prenatal, because that's what we're talking about today. These are the responses from the relevant training program directors. In pediatrics, we've been supporting, the East GMSA has been doing a lot of work to support training in pediatrics. It's a sort of key area for us, and so you can sort of see that they are aware of that training that's been going on. It looks like we didn't actually get a response from OBGYN, so we don't know whether they have incorporated it or not. It looks like there's, some of our trainers have low awareness of genomics, so they don't know whether this is even relevant to their training. Of course, it actually is, but we still have lots of work to do with our trainers. So one of the other things that we've been doing in the region is just trying to provide some sort of scalable resources that we can use in different settings. So we've developed some e-learnings as well. So these are the two that are relevant sort of for pediatrics and prenatal. So we do have an e-learning around having conversations with patients about sequencing, and we have an inherited cardiac conditions e-learning as well. And we are about to launch a rapid prenatal exome sequencing e-learning program. So that's just a broad sweep of what we've been doing, what's been going on at national and regional level in terms of the availability of resources. Okay, I think I'm going to go. Do I go straight on, Ian? Yeah.
Yes. Sorry. Yeah. Thanks, Gemma.
Brilliant. So I mentioned previously that we have been developing communities of practice because it's not just healthcare professionals in training that we need to reach. We need to reach the healthcare professionals who are not in training, who are already in practice. So this is an intervention that, we can't work with the deaneries on this. We have to do this ourselves in the system. So I'm just going to talk about how we've been thinking about this and the approach that we've taken. So what are we trying to achieve? In the genomics strategy, we are tasked with developing the capacity and capability of the workforce, meaning the multi-professional workforce of the NHS in our region. So we need to get this word capability. We really need to be getting these testing pathways open and active and happening. So I've already mentioned what we think about with mainstreaming, but what I want to draw attention to here is that this is not just about knowing stuff, this is about doing stuff. So we need our workforce to actually be able to do things. We need them to act on their knowledge. So they need to be able to order tests and have conversations with patients about genomics. So this is about capability, its ability to apply the knowledge and skills. It's not just knowing about genetics, it's being able to do something with that knowledge. This is slightly different from competency because capability can be attributed to a group or an organization or a team. But we are when we think about an education program, we're not just trying to impart knowledge and skills and raise awareness. We're trying to empower healthcare professionals to actually use this knowledge and skills in their workplace. So we have to think about the environmental aspect of this learning as well, and not just teach people knowledge. All right. So what sort of program should be? What's desirable for such a kind of mainstream education program? So we're teaching qualified healthcare professionals here. We're not teaching students or children. So these are high functioning healthcare professionals. But there are lots of them. So we need the intervention to be scalable. There's lots of people to reach, and there's not many of us. We are very focused around equity of access for patients to care, which means we need to think about equity of access for healthcare professionals to training. So we need to be quite systematic in how we think about this. And we also want it to be sustainable because the genomic strategy is forward-looking. The service is going to continue to evolve through research and innovation. So this is not just a one-stop teach people about genetics on you go. We need to actually have that continuous support available. And ideally, we would be able to measure whatever we put in place. So we could, when we're thinking about capability, particularly, we are thinking about the outcomes to the system. So an example might be, we might set ourselves a target of within the next 12 months, all paediatric groups within our geography will be ordering tests from the National Genomic Test Directory. So that's kind of what we could measure. So if we're thinking about how the technology sector looks at getting their innovations to their customers, there is actually a sort of model called the diffusions of innovation model, and this is how people adopt change. So we are trying to bring about a change in how people are practicing medicine. So when we think about that, it's not something that's going to happen immediately. We can think of ourselves as the innovators, the people who are bringing this forward, and then we will reach the early adopters, people like Jess, who you've heard from today in the hearing loss clinic, people who are interested, who want to take this on and who are motivated. But we also need to reach the majority of healthcare professionals who, frankly, may not really be that interested in genomics. So they're not necessarily going to engage with us, but they will be engaging with their colleagues who are their peers. And when those peers start to show them the benefit of adopting this particular approach, they will be influenced by them. So we need to think about user feedback on the service. So we need to make the service as easy to use as possible, and create some peer-to-peer networks, and think about the needs of each of these different types of groups that we're trying to reach, not just those early adopters. And if we go to educational theory about sort of looking at adult education and workplace education, and we're thinking specifically about capability, we are really deep into this sort of learning journey. So we're not just thinking about engagement, we're actually thinking about realization, so getting the knowledge into practice. And this is it requires us to take a hortagogical approach, and this is really where we've got the deep learner maturity, and they're autonomous, and we're really kind of supporting them rather than just telling them about stuff. So the features of hortagogical learning are that we would be, it's collaborative, you share knowledge and resources and information, you reflect on what's been learned, you create shared meaning, and you think about how to apply it in practice. So we're trying to bring together the scalability and also an approach that establishes capability. And one of the ways that you can do that is to establish communities of practice. So this is really where you've got groups of people sharing a passion or concern for something that they do, and they learn how to do it better as they interact with each other regularly. And this is really a scalable model for those with genomics expertise to support a large number of mainstream clinicians to implement genomics into their practice. So we've been running this in paediatrics for 3 years now, and we have monthly meetings 10 times a year, and we've got 600 paediatricians on our contact list. Many of them have attended some of our forums. We record all of our forums and make our slides available to this community. And some of the recordings have been viewed over 100 times. And we are also able to see that we have, more than 100 paediatricians from 28 trusts in our region ordering whole genome sequencing. So that's what I mean by measurable. This is just an overview of the topics. All these slides are available. You're welcome to get in touch with us and we can add you to our learning platform. We know that our paediatricians in our region are actually getting their education from this forum rather than through national or sort of professional resources. So people are engaged with this forum. This is just showing where the community practice sits in the whole big system. So people from different trusts all come together in a community of practice with people from the laboratories, with people from clinical genetics. And we are able to feed information back to the forum, new developments, for example. The people in the forum are able to take this back to their trusts. We can measure it centrally, they can measure it locally, they can present back to the forum themselves, and we all learn together. So just to conclude, we need scalable, systematic, sustainable educational approaches to ensure equity of access to genomic services, and communities of practice are scalable. We're thinking about capability. It's not just about knowledge transfer. It presents real life challenges that healthcare professionals as learners must overcome in their situation for themselves. And the community of practice model helps to support this capability. And this is also shows the importance of measurement and feedback of outcomes. So we are telling our community of practice how they are doing, and they are telling us about problems that they are encountering and how we can better support them. So it's a two-way conversation, and it enables us to know how far we've got along that mainstreaming pathway for each of the clinical work streams that we're working with. Okay, thank you. And over to Jo.
Thank you. I will try my best to speed up in the interests of time. But following on from Gemma's amazing presentation, we wanted to just do a little bit of information around the East Genomics Prenatal Forum. So why did we want to create this prenatal forum? I think Gemma's answered most of those questions. However, we know that in prenatal screening and diagnosis, care requires a unique set of skills to ensure that there is that high quality care for that pregnant person and their families. And families are coming into maternity services and not necessarily expecting their baby to have problems on scans. And I learned very early on from some training with antenatal results and choices that the moment a pregnancy test is positive, a couple are not imagining that things are going to go wrong, or they're going to have to make decisions on genetic testing, or whether they're going to continue or end a pregnancy. They're imagining that nursery or that baby in their arms, and as what I'm seeing on social media a lot of the time, it's how best to have that gender reveal party. So we really need to bring it into context of the meaning of these results, and the pressures there are on our clinicians as well, to ensure that they're providing the right amount of communication, testing options, and doing it in a timely manner to support those families. And as you've seen, that paediatric forum is an example of a successful addition to clinical support mechanisms. And due to that positive engagement from the forum, we really wanted to have that similar model within prenatal services. So, as Donna mentioned previously, there is the imminent implementation of prenatal networks of excellence, and that's to expand the access of innovative approaches to delivering prenatal genomic medicine. And so we felt that by creating that prenatal network and forum, we would have that strong local alliance to feed back to that national work, and also have that potential to identify and support those at-risk populations or communities, and lead to improvements in the quality of care and patient outcomes. And then through the R21 project, which you heard Kasia and Lauren speaking about earlier, it highlighted that variety of range of skills, roles and responsibilities, and that inconsistency across the pathway, not only within the teams, but across the geography. And since that work and the recruitment of myself and others within the GMSA, the engagement inquiries about genomic pathways has increased, and we have seen that there is that real desire to learn more about genomics within that prenatal setting, but we just have to get that platform right. And so from further scoping of the region, we've found that yes, there are already networks there, but there's not necessarily that setting to have that cross across sort of the East Midlands and the East GMSA. And we also wanted to provide that platform, as Gemma had mentioned, to give some of those national updates to make sure they are implemented locally. And so this is some of the comments from the R21 project, just to sort of have from clinicians saying that there is that need for education and that need for resources and refreshers just to keep everyone up to date. So again, we didn't want to do it just based on what within the GMSA we think is right. We wanted to build a forum based on collaboration with the trusts within the region. And so therefore we asked everyone to complete a survey to understand and develop those aims and objectives of the forum. And as you can see here, the clinicians wanted to cover a number of activities within that forum. So expert speakers, what's available in terms of research, and even skills sessions to really make sure that they're doing the best for their patients. And most clinicians were happy to organise and chair the events as long as they were supported by us within the GMSA in terms of that admin and dissemination of information. So we were able to provide a small amount of funding for those who chair the sessions to really help encourage the progression of this forum. So the survey shaped that terms of reference, and ultimately we wanted it to be a space where the whole MDT felt welcome. And again, sort of going back to some of those conversations with midwives, you know, there was a lot around district general hospitals being the last to know about testing, and midwives not really necessarily feeling part of those conversations. So we really wanted to get that MDT approach and make sure that everybody had the same level of information and education. We received support for 4 clinically led sessions over the year, and the aim is to evaluate that effectiveness following that final session in sort of December, January this year or next year. And the ultimate aim is to ensure that all teams within that East GMSA are aware of genomic services available for their patients within that prenatal service and ensure their equity. So very quickly, we've only had 2 sessions so far, but we're 50% of the way there. The first session was hosted by Cambridge's fetal medicine team, which was amazing. And it focused around that litigation when opportunities are missed. And it also discussed those implications to neonatal services when there's not a diagnosis. And again, this was to highlight the roles and responsibilities of our clinicians in ensuring testing was offered at the right time. We also had the privilege of having Jane Fisher from Antenatal Results and Choices attending to discuss some of those challenges for parents. We had over 87 clinicians registered for the event and over 60 attended. And some of the outputs from this was considering whether we needed further training and support for actually some of our charities and our support organisations, because we know the parents are going to these places, and actually having that up-to-date information and understanding of genomics could be beneficial. The second session was presented by the clinical genetics team at Leicester, and it covered a number of cases that looked at the fetal exome sequencing. And what was great about this session is it highlighted some of the tools, as you've seen earlier, that have been developed to assist that pathway. And again, we were excited to have a colleague from the Express study reporting on the experiences of parents and also considerations of families from diverse backgrounds to understand what some of those barriers are to screening. And And from that work, again, there's been further discussion about potential focus groups or working groups to understand what the barriers are within this region. And bereavement pathways has come up as one of those areas that is challenging. And Michelle, our colleague from Express, has also now had that wider reach of clinicians to report on their views and experiences of screening and diagnosis for Black women. And we've put a poster out for that. And again, hopefully Ian can share that following this event. And we noted actually with this session, so looking at this wonderful pie chart that I developed, that it's had further reach from more than just the GMSA. It's led on to other GMSAs and national interest. So it's got a really high attendance rate, which is fantastic. And I guess what I really wanted to show from this slide is that it is MDT. As you can see, we've got nurses, we've got midwives, we've got obstetricians, sonographers, etc., all joining. And actually on our last session, we had research teams and pharmacists. So we are getting there. What I am seeing is that there was a slight reduction in those nurses, midwives and obstetricians in the last session. And this is for them. This is for your obstetric fetal medicine teams. So we don't know whether it's a case of the interest in the topics or the level of information, or if it's just a case of capacity to attend these forums. And we do record them so that people can go back and review. But again, it's just a shout out to really get those people coming to these sessions. As I say, we're doing a slight we're going to do an evaluation after the 4 sessions, but so far we have had good positive feedback that it's really helped some of those local pathways and provided interesting cases to consider in practice. We have our session 3 ready to go on the 16th of September, and that's going to be hosted by the Genomic Laboratory Hub, and it's going to focus around those testing methods and technology with some interesting cases from the lab perspective. And I just wanted to say that I think this one is going to be really important for our clinicians to attend, because some of those misunderstandings around practicalities and processes are where some of those delays can be for those patients having tests or getting results. So I really encourage you to sign up. So as I say, we're only halfway through this project, and we are keen to get our final volunteer to chair the session in December, January, prior to the evaluation. And as I've said, there's been a lot of discussion on those bereavement services. So maybe this is an ideal opportunity for someone who's interested in that area to chair and bring in some speakers or some national research. So if you are interested, please do get in touch. We then also need to evaluate the forum and identify if this is something that should be continued. And we need to understand is how the trust can be leading the way within this network. Finally, we wanted to review some of those discussion outputs and suggestions to see how best the East GMSA can support the improvements across the patch. Needless to say, we are nowhere near the level of the Paediatrics Forum. However, so far I've seen that there is a lot of interest in this space, not only regionally, but across England too. I just also wanted to highlight that this isn't the only learning platform that we're doing in terms of obstetrics. We have a number of lunch and learn and education sessions, and we've also got a national and regional midwives in genetic and genomics forum, which is growing. So I'm going to see if Donna's still here to speak. If not, I'll go on to the next slides, Ian, and carry on. So I think unfortunately Donna's had to disappear.
Yeah, I think she's dropped off, Jo.
That's fine. So bear with me with these slides. But really, we wanted Donna here because she has developed an amazing network of midwives over the last 2 years. It's really growing in numbers, and it's up to, I think, about 50 people. And And the aim of the group is to work together, collaborate on national priorities, support and advise on regional projects. It's to share updates, progress and learning on good practice of embedding genomics into midwifery. It's also about that peer review and opinions on professional challenges and barriers to implement. So it's really good of how we're trying to go from a regional perspective, building up to national, but also feeding back down. And we also feed into the nursing network as well, where it's appropriate. So you can see from this slide, we've got all the lead midwives from the genomic medicine services. We've also got core representation from fetal medicine and screening midwives, research teams, chief nurses and midwives, diabetes specialists, educators, genetic counsellors, the list goes on. But there is such a passion around getting this right for our patients. We've got several work packages which will feed into the prenatal genomic network of excellence. And so one of those, as Gemma mentioned, is thinking about that midwifery toolkit to support educators in the pre-registration space. Another area that we've focused on is based around that national testing directory. So within the MiGGs group, we had a presentation from a local project identifying that NIPT would be available for women who have had a previous pregnancy with either Patau's, Edwards or Down syndrome, which we all thought was fantastic. However, it highlighted very quickly that although there was going to be a rollout within that testing directory, nowhere near were those midwives ready to have that in their service. So what that would mean is that some who had already been doing it would lead the way, and there would be that inequity of access. So as midwives within that MiGGs group, we developed a task and finishing group and collaborated with some of those key experts and national leads to have a methodical and coordinated rollout. We developed a high number or several resources to support that R445 rollout. So we went through the National Screening Service to make sure that the communication reached all screening and fetal medicine midwives. We also ensured that we had a clear pathway for those healthcare professionals, and also information for parents, because it's very different from those that are just entering the national screening pathway. So we wanted to make sure that that information was appropriate for this group of parents. We also have developed some information for G-Notes that Gemma has mentioned, and we have a training module under development. So a few other things to come, but it just shows the way that a network can work to get a positive outcome and ensure that we're supporting our staff on the ground. And I think that is it. Thank you very much.
Thanks, Jo. That's great. I'm just here to introduce a couple of patient stories that we've got lined up. Unfortunately, both sets of patients couldn't attend today, so we've pre-recorded some interviews with them. Firstly, we have Laura Tim. Laura's on our PPV panel, our Patient and Public Experience panel. Laura's daughter Eleanor was born very poorly with intestinal failure and was admitted to the high dependency unit at Norfolk and Norwich Hospital very shortly after birth. And in fact, Eleanor went through the Next Generation Children's Project, which we've heard about from Austin and Helen. So that's our first case study. I think I'll introduce our second one when we get there. So if all of the technology works, here's Laura Tim talking about her and Eleanor's story.
For the most part, my pregnancy was completely normal, and we were blissfully unaware that anything was wrong with Eleanor. I had at the time, 2.5-year-old as well, and she was perfectly healthy, so there was no reason for us to think there would be anything wrong. also because of the field of my work, I was involved in circulating DNA tests. So I was quite interested in the Harmony test. And being a slightly older mum, I had the Harmony test done at 10 weeks of pregnancy, and that came back completely clear. So obviously we just kind of assumed everything was fine. It wasn't till we got to around 34 weeks that the midwife did the fundal growth measurement, and she thought that Eleanor wasn't growing as she should be. So she sent us to our local hospital for a growth scan. As it happens, she was growing absolutely fine. But that growth scan picked up some dilated bowels, which were really quite clear on the screen, and I sort of questioned it. So she went out and got a consultant, and we were referred to fetal medicine, who had a discussion with us, and they had a discussion with the genetics team at Cambridge to see if there was anything sort of that immediately sprung to mind as to what could be going on here. And there were discussions around, CVS, genetic testing at that point, even termination up to 36 weeks was mentioned, but that wasn't something I wanted to do. So that was kind of the point where we realised something wasn't right, and there would be further investigations when she was born. So when Eleanor was born, she quickly became unwell around 3 to 4 days after her birth. Luckily, we were still in the hospital at that point, and she was sent to the neonatal intensive care unit. She was severely dehydrated. She had metabolic acidosis. She wouldn't tolerate feeds. She had, we didn't realise at the time, but chronic diarrhoea. And she was just really very, very unwell. She lost a huge amount of weight. The consultants conducted test after test. Everything came back negative. We really had no idea why she was so poorly. And being kind of scientific myself, I'd leave the NICU late at night and I'd go home and I would just spend hours researching, just looking for that similar case presentation, reading research papers, case presentations, etc. And I came across one case of a child with a condition called microvillus inclusion disease, which is a congenital diarrhea condition. And it just mirrored everything that happened with Eleanor. So I took the paper to the hospital, to the consultants, but unfortunately they didn't really give it much credit. But I was convinced that this was what she had. And it was caused by a mutation in the MYO5B gene. So working in the area of genomics as I did and having contacts at the genetics lab, I spoke to a colleague and asked if they had any kind of tests or panels that would look for this gene. Unfortunately, they didn't, but my contact at the lab then referred me to, it was a clinical trial going on at the time called Next Generation of Children, and it was sequencing the whole genome of children who were clinically unwell in a NICU or a PICU setting, which just ticked the box for Eleanor, So I went back to the hospital and I spoke to the consultant who was the referral lead for Norfolk and Norwich, and she completely agreed that Eleanor was a candidate. That afternoon, my husband, Eleanor, and I all had blood taken, and the sample was sent off, and 3 weeks later, her genome was sequenced and we had a result, which just absolutely floored me, because working in this area and knowing how long people have been waiting for results with the 100 Genome Project, I didn't expect it that quickly, but it was, 3 weeks. 3 weeks was still long to wait when you've got a sick child, but to get a result quickly was amazing. Eleanor was diagnosed with 2 genetic conditions, which again was a surprise. One was a mutation in the UNC45A gene, which was causing her problems with her intestines and her inability to absorb any nutritional fluids. And the UNC45A gene is involved in a protein called myosin chaperone protein. So it's very similar to the role of the MYO5B gene, which I initially thought she had a problem with. But it was actually even rarer than microvillus inclusion disease. So again, that really kind of floored us. At the time of diagnosis, Professor Raymond, who was the lead on the trial, came to visit us to actually give the diagnosis. And she'd managed to find a paper that had been published just a year prior to Eleanor's diagnosis, discussing 4 other patients with this condition, and this is worldwide. So as far as we knew at that point in time, Eleanor was only the 5th child worldwide with this condition, and they call it osteo-otto-hepatoenteric syndrome. So it's got these 4 etiologies, osteo being bones, otto being hearing, enteric being intestines, and obviously hepatic being liver. So there's potential hearing loss, brittle bone disease, liver, cholestasis, and intestinal failure are the 4 kind of things that can cause this syndrome. And each child, depending on the specific variant they have within this gene mutation, presents very differently. So there were 2 sisters in the paper who presented much more with liver problems. 2 of the children had more of the intestinal problems. Some had hearing loss, some didn't, some had bone fragility, some didn't. So for us, it was a kind of, okay, we know she's got intestinal failure, but we don't really know anything else at this point. So again, it was just so rare that we didn't really know what to expect, and we couldn't base anything on case studies or history of a condition, etc. And she was also diagnosed with mitochondrial disease, which turns out that I had passed on to her, and we have in our family. But fortunately, at the moment, she doesn't have any problems associated with mitochondrial disease. It's something that may cause problems for her in the future, but right now, her condition is caused by the mutation in the UNC45A gene. So initially, the diagnosis, it allowed me to stop kind of researching and looking for answers, and I could just say, okay, I've got an answer now, and now I can just be mum, and I can be there and look after her and do whatever she needs. From a clinical perspective, it meant that our team could make appropriate referrals. We knew she had intestinal failure. We knew she was never going to tolerate any feeds, that she, in order to survive, would need something called parental nutrition, which is basically a bag of fluid that has all your fluid and nutritional requirements in it, and it's delivered intravenously, sort of directly into the heart. So we could just, instead of carrying on doing tests, and we could just move forward really quickly. So we were referred to the intestinal failure team at Addenbrooke's, and we went there pretty much straight away. They did a few tests, but we ultimately knew what she had. You know, they took biopsies. We had a look at the state of her bowel. It was really clear that she had a lack of microvilli, so she was never going to absorb anything. So they then trained us up as parents to be able to give her TPN every day at home. So I think from a time perspective, it meant that we weren't in hospital for as long as we possibly could have been, and we could exclude a lot of stuff, so we could really focus on what needed to be done. Obviously, knowing that she had potential for other conditions as well, they were monitoring her liver health. Being on PN in itself is a risk factor for your liver, so they were, really great at monitoring her liver. We ended up under the ENT specialists at our local hospital as well. Later on in her journey, we have discovered that she does have bone fragility as well, and she's had multiple fractures that we've not been aware of. So, and I think as a family, it just having a diagnosis, although we don't, we can't say this is going to happen for Eleanor, we know this is what it is. We know how we've passed it on to her. So it's an autosomal recessive condition. So both me and my husband have a defective gene that we've passed on. So we knew if we were to have more children, there was a 1 in 4 chance of us passing it on. So we'd always thought about having 3 children, but understanding this condition has kind of, and what we face with Eleanor in day-to-day care has kind of knocked that on the head. So yeah, I think it's a lot of it is really just peace of mind and understanding. At the age of 2, she had a liver biopsy and it came back cirrhotic. And at that point, her gastro team at Addenbrooke said she really needs to be referred to the transplant team down at King's College Hospital, which was a surprise because we weren't expecting that so early on in her journey. So she was assessed by the King's College transplant team and she was listed for a small bowel and liver transplant, as well as colon and pancreas, so she received 4 organs. We were listed in June 22 and she received her transplant in October 22. It was a difficult time. She spent 5 months in hospital. She had multiple complications. Because Eleanor ended up so unwell towards the end of her listing, the maximum weight of her donor was increased to 40 kilograms, which was 4 times her size. The actual donor weight of the organs she received was 30 kilograms, so 3 times her size. So because the organs were so large, they couldn't physically close her abdomen, so she was left open, which had a lot of complications in itself. It took months and months for her to actually heal herself over, as you can imagine, with a massive wound like that. And she developed lung complications as well. So it was, a very, very difficult time. But ultimately, as a family, we knew we had no choice but to take this route because she wouldn't survive without it. She now has a functioning bowel and a very healthy liver, so we don't have to worry about that anymore. Her hearing is good. She is completely off TPN. She's now off peg feeds, so she eats and drinks orally, and boy does she eat and drink. She loves her food. So I think the fact that she is well nourished now hopefully means that the hearing won't be impacted. And also, touch wood, we've not had a break in a bone since April last year. So again, she's absorbing her calcium and getting her vitamin D. Does that make a difference to her bones, or is it more genetic? We don't really know at this point. So those fears have kind of gone, but now I have more fears because she's post-transplant. Bowel transplants historically don't last very long. She's immunosuppressed. So I've kind of swapped one set of fears for a whole other set of fears. But, we've been given this amazing gift and this second chance for her, and we really do try and make the most of it and live every day as it comes and enjoy it. But if another parent was in my situation, I know it's the desperation for answers. You need to understand, for me, I can cope with anything. I just need to know why, so I can then put a plan in place. And if tests aren't giving answers, it's really hard to live with that unknown. So sequencing is absolutely fantastic because it will look at everything and it should give you those answers, even if they are really rare and not necessarily well understood. It can give you something, and you can stop searching for answers and just focus on being the parent that you need to be for your child. For a healthcare professional, I would always say, you know, especially now with the way things have moved forward in the last few years with sequencing and the test directories, you know, always consider it. If you're not getting those answers, always consider sequencing. It gives you quick answers, and it, you know, it will look at things that you might not necessarily think to look at. We would have never have thought to sequence the UNC45A gene. So it was only because we sequenced the whole genome that we actually came up with those answers. So I think that's why sequencing is invaluable, whole genome sequencing is invaluable, because it really does give you those answers, and it allows you to then all move forward with a plan, knowing exactly what you can do for that child.
And that's Laura and Eleanor's story. Just going to very quickly move across to Kirsty and Andy Cross and their son Rory. This is just another very short video, just under 15 minutes this one. Rory was born very poorly, very similarly in many respects to Eleanor, and underwent rapid genomic sequencing at Addenbrooke's Hospital. And this is a pre-recorded package with Kirsty and Andy to talk through their experience of testing and beyond.
Yeah, in theatre when he was born. He was born by elective caesarean at 39 weeks, had a completely typical pregnancy, nothing weird or wonderful, second pregnancy, so was very, as we would expect, and then he was born not breathing. And very quickly he was taken away to neonate. We didn't even have a chance to meet him, did we?
No.
And then it was from that day, the very long list of things that were wrong with him were made quite clear to us, and then it was on that very day that we had our first genetic testing done. So yeah, that was sort of where the world of genetic testing became familiar to us.
I think selfishly you just never think it will happen. You know it happens, you know you get poorly children and you know things like that, but you just never kind of comprehend that it could happen to you, selfishly or not. But
you just think it happens to someone else. You think other people have children that are born with weird and wonderful
and it's
conditions,
horrible to say
and
that,
yeah, you know, and we wouldn't change him for the world now. But on that day, we'd gone into hospital for 7 o'clock in the morning for a planned delivery, and
you just expect
your world is turned.
To plan, don't you?
Yeah, you expect it to go to plan, and yeah, your world is turned upside down in that moment. So from the moment he was born, he just couldn't breathe how he was expected. How you expect to breathe. Everything that we take for granted, he couldn't do. There was he couldn't feed whilst breathing. It was one or the other. We had some very scary episodes here at home where he just stopped breathing altogether. His issues boiled down to breathing, didn't they? He had other symptoms of genetic conditions. He was hypertonic, he has distinctive facial features, so that goodness me, so they sort of triggered the genetic testing, but his overriding symptom was breathing distress. He was requiring significant oxygen, he had a nasogastric tube because he couldn't feed and breathe, and all of his issues boiled down to breathing. There were other distinctive features about Rory, which is why the doctors pushed forward for genetic testing, but the overriding issue was breathing distress that wasn't getting any better. You know, hours after birth, things weren't improving, and there was just kind of no reason for that that they could work out, and that was where that, along with the other little markers that pushed forward for the genetic testing. I think if you break a leg or you break an arm, you know it will heal. And you know, my toddler, he comes home with bumps and scratches and all of that. I just couldn't comprehend that we had got a tiny newborn that couldn't do the one thing that he was required to do to live. And
we didn't have an explanation.
We didn't have an explanation, and while he was remotely stable in hospital, I could see no way of us getting home. It was like, okay, all of these things that they are doing are keeping him stable, and we appreciate all of it, but he can't live here. This can't be a forever thing. So what can be done in order to try and help us get answers and move forward from this? And yeah, that was sort of our overriding, like, okay, this is his issue, and if we can't move forward from this, where do we go? There was lots of very scary diagnoses thrown around that day, wasn't there? Things that they thought it perhaps might have been. It actually is none of them, but it is something else exceptionally rare. But, you know, yeah, very, very frightening. Very, very frightening as a as a new parent again. Yeah, and not knowing sort of how the future would look, or, you know, whether we would get to keep Rory, or, you know, yeah,
it was quickly digest that. Maybe.
Yeah, you had to very quickly digest it and just think, actually, we've just got to get on with this. This is the hand we've been dealt, and we will deal with it as best we can. Just hoping that he would be okay, and, you know, hoping that we would be able to get some answers so that we would be able to do something to help him.
I think at that point we're still thinking optimistically, like everything would be okay.
Yeah, I think there was partly that, okay, they're running these genetic testing, but, you know, we said before, Jess is our son, you know, and he'll be all right, you know. We'd Googled that some babies that were born by cesarean did struggle to breathe, and we put it down to that. But, yeah, very quickly we realised that perhaps wasn't going to be the case. At the time, we were dealing with each other only over the phone, and I spoke to the genetics team over the phone because they'd gone to see Andy, but they needed to speak to me too. It was just, we just couldn't be together, which was really, really difficult during that week.
And we had this thing at the time where I'd say I was the optimist and you were the pessimist.
We've always had we balance each other out well right from the get-go with Rory. Has he been the optimist and me the pessimist? Because
going into Addenbrooke's with just me and him threw me off a little bit.
Yeah.
With all the scary things that, you know, neurology, for instance, came to see us, and they threw out all these things that it could possibly be. You know, like muscular conditions, and, you know, and that was scary for me. That was one of the scariest days, I think, of it all.
Yeah, I think
Whereas
so.
I kind of took it all in my stride a little bit, but then that just threw me off guard totally.
Yeah, and then since then you've taken it all in your stride, but that week was particularly tough. He was only 5 weeks, and he went under general anaesthetic for ENT investigations, not a procedure as such, because no one just knew what they were dealing with. And it was that week that we had and me and you also had our blood tests too. All three of us were tested to try and get to the bottom of what was the matter with Rory, and we did eventually, didn't we?
Yeah.
And actually the diagnosis was not as big and scary as it perhaps could have been. So for us, diagnosis day was a relief, wasn't it?
I think that first trip to Addenbrooke's probably hit home with me how serious this actually
could have been.
Could be,
yeah.
I didn't know an awful lot about it, and I think I signed the forms for the consent at Addenbrooke's when I met the genetic specialist, and he explained it, you know, all these medical terms and, you know, this, that and the other, and I was just like, yeah, if this is going
to help us move forward, absolutely. And we would say the same to anyone that was in our position that may be slightly nervous about genetic testing, because sometimes knowing can feel just as frightening as not knowing, but pushing forward and getting an answer in order to get the medical help and just awareness of what you're dealing with. We knew nothing, if I'm being honest, did we?
No.
Nothing at all. We knew slightly more once we had our initial first diagnosis at 3 weeks. We knew he had a microdeletion of uncertain significance, but that didn't really give us any insight to what it could or couldn't be. And then it was during that week that we were told about the sequencing and the results of the test, the blood would go to Exeter, and you know, the turnaround was quick. And it was that we were like, okay, well, we're going to do this because he's still very poorly, we're not getting anywhere right now, and this is really important. So albeit it could be something terrifying.
It wasn't just us, was it? It was the doctors didn't really know.
No, they weren't really sure how to treat him.
They were just trying to manage him with the oxygen, but there wasn't really an end game. Like, it wasn't like, oh, you know, we can treat him, we can use this treatment or whatever because we know it's this. Yeah, I think it was helpful as well to the medical professionals knowing what this was, so that we could have like a plan almost to get him home.
Yeah.
Because at that point there was no
hope of coming home, because we still had so much that he needed to wean off. You know, he wasn't taking a bottle, he was on oxygen, you know, there was all of these things that we couldn't come home with, because you don't bring typical children home with those things. So yeah, getting to the bottom of it so that we knew what we were dealing with, and knew, you know, so that we knew what we were dealing with and they knew what they were dealing with was important. And we knew that this type of testing would give quick answers, and because he was still so poorly, we were able to have it, weren't we?
So yeah, I met the genetic specialist and he explained the whole genome sequencing to me, and I signed the consent form, and I just couldn't believe how quick the turnaround was for this. I think it was a fairly new kind of thing they were doing, you know.
And we knew that not everyone qualified for this type of testing, but because Rory was as poorly as he was, with no view of getting any better or no view of discharge, we qualified for it. And yeah, we had our answer within 2 weeks of that date. So by the time we had our blood tests over at Addenbrooke's, Rory had his done at Addenbrooke's, and then we within 2 weeks we had our diagnosis day. It just gave an answer. So we knew, albeit it is a very, very, very ultra rare genetic condition, he's one of 13 in the world, but the main and overriding symptom of that condition is respiratory distress, which is everything that Rory had in abundance. So it just it was like, okay, this doesn't help the here and now, because right now he's still struggling, but this is why. And everyone could then put into play.
Yeah, it allowed them to put a care plan together to get him home.
To get us home.
And that's, you know, we knew what we were dealing with now. We just wanted him home at that point.
Yeah.
And it allowed us to do that.
So
and you know, people wait
years, you know, not necessarily for the testing, but because lots of Rory's symptoms could be passed off as bad luck. But actually he had this condition, and the things that we've come home with is everything that keeps him stable enough to be here with us. And a lot of that wouldn't have been accessible without the named condition and the sequencing. It's unknown. We are still dealing with a lot of unknowns. He is still ultra rare, but we feel the future's bright. You know, we know that we've got our genetic specialist on our side. You know, we're using Rory to help with further research, so that we can not only help him but help other families that are going through, even like there's so many rare conditions that sort of all are very similar in so many ways. We're just trying to armour ourselves with as much knowledge as we can in order to be able to help him moving forward. He's not showing any signs of giving up his oxygen anytime soon, and life will always be ever so slightly different than how we perhaps planned it to be. But because we know what we are dealing with, we know how we can help him and how that we can potentially live a more normal life again. And we've spent a significant amount of time at home now, big periods of time at home that we weren't getting before.
Big steps since we've come along. He's come a long way.
He's come a really long way, and I know that.
But it's still taking each day as it comes, because he still throws curveballs. Like last week, he done 3 nights in hospital, which is nothing compared to what he went through last year. But
he's just reminding us that he is still that little bit fragile, a little bit different, and the need to protect is still there and fierce. And yeah, we will just take as much guidance as we can, you know, as new things crop up for Rory, we speak to the genetic specialist so that we can get those things noted down, so that they become, the folder becomes bigger and bigger and more filled with information. So moving forward, we just have a little bit more what everyone's dealing with. Information is power, and when you are dealing with very poorly children, your own children, you know, personal connections to you, you'd be amazed at just how many rare conditions there are and how many people are actually affected by these. And if people can have diagnoses early, you know, really early on in life, their quality of life will be entirely different to how perhaps it would have been. Yeah, we stand firmly with testing and knowledge being power, don't we? And yeah, it's helped our family massively.
Once again, thank you for everybody for putting these showcases together, and also for everybody participating. So I don't know if there's any other final words from anybody, but we've also got, I think, some links into providing your thoughts about this, which you can see on screen now.
Yeah, Ian's just put that up, the QR for feedback. So please do give us feedback. We will certainly hope to improve on the series that we've just hosted. So thank you, everyone, and thank you for your time. And as promised, 1:30 we will close. So have a very good afternoon, and hope to see you at our next series of events.
Great. Thank you very much. Bye-bye.